Hi, welcome. I'm Jill Harlan. I'm the Program Director of Community Liver Alliance, and I'm thrilled to have all of you here to join us for another virtual education event provided by Allegheny Health Network. This program's been designated for 2.75 AMA PRA Category 1 credits. Providers should only claim the credit commensurate with the extent of the participation in the activity. Can we go to that next slide, please? Thanks. So as you can see on this slide, we'll need you to send a text to the phone number listed there. The text is TATCAC. That gets you into their system. After the program, you then log on to the listed website there. You will fill out an evaluation. And after that, you will immediately receive the CME certificate to either download or print. Don't worry, if you don't remember any of this, I will send you an email after the presentation. The important thing to remember is that the CME ability to claim the CME is only good between the hours of 6 p.m. today and 6 a.m. tomorrow morning. So you want to get that. I will send the email out at 9 p.m. promptly after this conference, and you have to interact immediately to get that registered. Any disclosure of significant relationships with relevant commercial companies in accordance with the Accreditation Council for Continuing Medical Education and policy of Allegheny General Hospital presenters must disclose all relevant financial relationships, which in the context of their presentation could be perceived as real or apparent conflict of interest, ownership of stock, honorarium, or consulting fees. Any identifiable conflicts have been resolved prior to this activity, and any such relationships will be disclosed throughout the program. I would also like to thank AbbVie, ISAE, Allegheny Health Network, Genentech, and Gilead for their sponsorship and support in educational programs such as this. Without them, this would not be possible. So we are greatly appreciative. Now, it is my pleasure to introduce you to another program coordinator, Dr. Julie Marone with AHN. She has been the program planner for this activity and instrumental for developing tonight's agenda with speakers. Please join me in introducing Dr. Marone.
Thank you, Jill. It was my pleasure to work with you and the planning committee to bring this information to our colleagues tonight. I am Julie Marone, and I am an internal medicine resident at Allegheny General Hospital and the planner tonight for tonight's liver update. Tonight, our program will bring key findings to focus on current trends, management, techniques, and innovations, and research to treat a full range of liver conditions. These include NASH, liver transplantation, portal hypertension, hepatocellular carcinoma, cholestatic diseases, viral hepatitis B and D, and alcoholic liver disease. It is now my pleasure to introduce to you our course director, Dr. Michael Babich. Dr. Babich completed his undergraduate training at medical school at Boston University and his internal medicine training at UPMC. He completed his gastroenterology and hepatology fellowship at VCU, formerly Medical College of Virginia, in 1997. Directly after his fellowship, he joined the teaching faculty at Allegheny General Hospital, where he has served as the GI Fellowship Program Director since 2009. He is a practicing hepatologist and remains involved with the training program to foster his love for teaching. Without further ado, I introduce to you Dr. Michael Babich.
Thank you, Julie and Jill, for that wonderful introduction and for all your work in bringing this program to life tonight. As Julie mentioned, I'm Dr. Mike Babich. I'm the course director for the evening and one of the co-moderators for tonight's liver update. It has been a tremendous pleasure working with the planning committee and the Community Liver Alliance to bring you tonight's program. I am especially delighted to have been able to work with my co-course director, Dr. Karen Kroc. By way of introduction, Dr. Kroc is a native Philadelphian. I don't know if is that a word, Philadelphian, and now works as a professor of medicine at Penn State, Milton Hershey Medical Center. She serves as vice chair for clinical affairs for the Department of Medicine. She's the associate program director for the GI Fellowship Program and the medical director of the liver transplant program. She's currently vice president of the Pennsylvania Society of Gastroenterology. She enjoys spending time with her family and watching them play soccer, basketball, and performing on stage. And it's my great pleasure to introduce Karen, Dr. Kroc.
Excellent. Thank you so much, Dr. Babich. And yes, for those of you on the western state part of Pennsylvania, Philadelphian is a real word. So thank you so much for inviting me to work with you and our planning committee to bring this slate of amazing thought leaders in the field of liver to present at tonight's program. We truly have a fantastic lineup of experts in the field to provide up-to-date information on fatty liver, NASH, transplantation, viral hepatitis, alcoholic liver disease, cholestatic liver diseases, and an overview of the Baveno guidelines for portal hypertension. Each talk is 20 minutes with question and answer, and you can put your questions in the chat box and we will address them to be answered at the end of each session. We might also address some of them during the talk as it's ongoing as well. So it's my absolute pleasure to introduce our first speaker, Dr. Dina Halegua. I think I just pronounced that wrong, even though you told me how just to pronounce it, DiMarzio. I apologize, Dina. She's going to be talking on NASH treatment innovation, and that's embarrassing because I have a hard name to pronounce too. But after obtaining her medical degree and graduating at Temple University School of Medicine in Philadelphia, she completed her residency in internal medicine and fellowships in gastroenterology and transplant hepatology at Thomas Jefferson University Hospital. Following her fellowship, she joined the faculty in 2014 at the Sidney Kimmel Medical College at Thomas Jefferson University as a full-time transplant hepatologist and is currently an associate professor of medicine. She developed the first adult fatty liver center in the Delaware Valley and currently serves as its director. She also has taken a major role in medical education at Jefferson, serving as the Transplant Hepatology Fellowship Program Director. She has been recognized by the House staff at Jefferson as Teacher of the Year for her specialty in 2016 and 19. And in the Sidney Kimmel Medical College Education Honor Roll in 2020 and 2021 academic years. Her main areas of focus include non-alcoholic fatty liver disease and drug-induced liver injury. And her research has been presented internationally and published in numerous medical journals. And so as you can see, she's very qualified to give us an excellent talk on NASH treatment innovations. Thank you.
Oh, thank you so much for that kind introduction. And yay, another fellow Philadelphian. I agree, definitely a real thing. Well, great. Well, we'll jump right into the presentation then. And I want to give you an update on non-alcoholic fatty liver disease. Again, this was a huge topic at the liver meeting this year. And I think the whole postgraduate course actually focused on non-alcoholic fatty liver disease. So I'm going to take you on a whirlwind tour of what we learned at the conference. Next. These are my disclosures. Next. So over the next 20 minutes or so, I want to first just talk about where are we in terms of NAFLD and NASH, in terms of the pathophys, the nomenclature, and some changes that may be coming. We'll talk a little bit about the prevalence, some of the newer non-invasive tools that we learned about at the meeting, and then some of the where we are with some of the exciting emerging treatments. Next slide. So we all know that non-alcoholic fatty liver disease is a disease with a large spectrum, and it's a progressive disease. We think that it starts in someone with metabolic syndrome or genetic risk factors, that the hepatocytes become less responsive to insulin. It's this insulin resistance in the liver that leads to fat buildup, hepatic steatosis. And over time, in up to 47% of people, they can go on to form NASH. And in patients with NASH, they are at risk of developing cirrhosis. And the statistics have changed over time. The more we've learned that, again, this is progressive. And up to 50% of patients with NASH can go and develop cirrhosis. And we'll hear tonight about all the other complications with cirrhosis. But you can see this is a very variable disease. And what's complicated is that this can happen very quickly or take years, decades. So, again, something we have to keep our eye on. Next slide. So I wanted to bring your attention to something that was discussed at the meeting, the thought that we may be moving towards changing the name from NAFLD to MAFLD, metabolic associated fatty liver disease. The definition of MAFLD is the diagnosis made with hepatic steatosis seen on imaging, plus at least the presence of one other condition such as obesity, type 2 diabetes, or metabolic disease. What's different about this diagnosis is that it's not a disease of exclusion like previously, where we would, patients who had alcohol use, we would exclude them from this disease. It's more inclusive. Which I think is a good thing, where if we're acknowledging that this disease has this metabolic background and a patient may also have alcohol use, and we all know about this gray area, it just may alert us that there's more patients out there that need treatment. Definitely some considerations, and there's a lot of talk going on. You may have seen this recently in some journals as well. What is metabolic syndrome? What about alcohol? How are we going to deal with that? But truly, we just need to get all of the stakeholders on the same page before this will actually become a change. Next slide. And again, I think it's a good change. So we're going to focus on just identifying patients and being able to treat them. Unfortunately, this is really important because over the next, this was a study was first in 2015, but over the next 8 years, by 2030, we're expected to see this exponential rise in the amount of patients, not only with NASH, but those with advanced fibrosis, cirrhosis, and the scary thing on this slide to me, 178% increase in liver-related deaths due to NASH. And this mirrors much of what we're seeing in terms of the diabetes epidemic. So it's very important that we learn ways to identify these patients non-invasively and to treat them. Next slide. And this was a poster that we presented at the liver meeting. I thought it was kind of interesting. That study I just showed you previously was a model that was trying to predict what things will look like in 2030. But what about COVID-19? So we decided to survey our patients with NASH, and we had 312 patients respond to our survey. And really, it was surprising, not really surprising, I guess. We've all heard about the COVID-19, but how's that affected our NASH patients? And of our patients, 39% thought that their dietary habits worsened, and 51% thought that their lifestyle habits worsened. So I'm scared to see what this last 2 years is, how this is going to impact NASH and the epidemic. Next slide. So as we jump into everything, I just want to remind everyone where we are in terms of the current guidelines, with NASH. So across the board, the AASLD, European Society, and the American Diabetes Association, finally in 2019, have all jumped on that patients with diabetes or metabolic syndrome should get screening. So if you identify a patient with abnormal liver tests or imaging with hepatic steatosis, we do need to take this further in terms of identifying if they have advanced fibrosis. Next slide. And this is, again, just to emphasize the importance. This was a study that was presented at the liver meeting, has recently been published as well. But patients with diabetes, I know I've been harping on that, this insulin resistant diabetes, but this is really the biggest risk factor we need to look out for. We've always known that this was a risk factor, but this is data where they followed patients in a diabetes clinic and did liver biopsies or offered liver biopsies in patients with elevated ALT. But the prevalence of NASH in this group was 58%, and 38% had advanced fibrosis. This is double what we thought previously. So, again, this is a group that we really need to pay attention to and identify. Next slide. So let's talk about what options we have. And I put this up here more for historical, analysis. This is so far the tests that we have available in terms of non-invasive tests. You can see there are some simple scoring systems I'm sure you're aware of, some blood markers, some tests that you can order through labs, and then elastography, which has really revolutionized things. But we haven't gotten to the point that we're able to get rid of the liver biopsy. But I think we're getting very close based on some new data from the liver meeting. Next. And just to kind of show you that, one test alone is not enough in many cases. All of these tests have this indeterminate range where it's really hard to identify if the patient truly has advanced fibrosis or not. Again, if it is clear on one end or the other, that's easy. But if we can shrink down this indeterminate range by adding 2 non-invasive tests, then we can start to mimic the accuracy that we can get with a liver biopsy. Next. And one of the scoring systems that sets out to do this is the FAST score. And this has been presented previously, but again, at the liver meeting, this was reviewed. The FAST score combines liver stiffness using VCTE or FibroScan, CAP score, and AST. And they've shown really excellent positive predictive value and negative predictive value, as you can see here. And what was interesting at the meeting, they showed that we could actually use this scoring system to monitor patients. So improvement in this score is similar to what we would see in terms of histologic improvement on a liver biopsy. So I think this is going to be a really dynamic tool that we can use for patients in terms of not only diagnosis, but also monitoring. And can be easily calculated in the clinic if you have those variables available. Next. Another scoring system that was unrolled at the meeting was the Agile 3+ and Agile 4. This is specifically for patients with advanced fibrosis and cirrhosis, stage 3 fibrosis or stage 4, and combined the FIB measurements that you would get from the FIB-4 with liver stiffness. And you can see from this table that it was able to show better accuracy than either of these scoring systems individually. So, again, pretty easy, usually data that we do have available, but can increase our accuracy and be used. So you're going to be seeing more of this, but this was a very large cohort and really promising data. Next slide. And I think from here, things are only going to get better. This fascinated me at the meeting, the idea of a liquid biopsy. Again, this was a small study, still really early data, but using this special proteolytic cleavage biosensors, this group was able to show that they can identify NASH versus a patient not having NASH 100% of the time. Again, small, only 88 patients. But it wasn't affected by gender, obesity, type 2 diabetes. It was really very, very accurate. So I think we're going to see more technologies like this moving in the future. And hopefully one day we'll just order a liquid biopsy and be able to identify these patients. We're definitely going in the right direction. Next slide. All right, well, let's jump into treatment of NASH and what we learned at the meeting. Next. Well, in terms of diet, I thought this was interesting. This was also presented at EASL last year and then reviewed at the meeting. But I think we all struggle as physicians on what diet our patients should be working on, and there's no one size fits all. So it's good to learn that we may have some other options. And in this case, the low carb, high fat diet, similar to what we call the keto diet, and intermittent fasting diets were shown to be very effective in helping reduce hepatic steatosis using MRI-PDFF, as you can see here, significant decrease in liver fat fraction using these diets in comparison. Sorry, if you can go back. In comparison to standard of care, which is like just telling your patients to do a low-calorie diet. This was exciting. I know we've been a little bit hesitant to recommend the keto diet and those types of high fat, low carb diets to our patients, but this data supports that this could be useful for patients, effective, and just some other things that we can offer in terms of dietary changes. Next. What about bariatric surgery? We know that there's been extensive data from France that bariatric surgery definitely helps in terms of being able to reverse NASH and steatosis. But this data from the Cleveland Clinic, and this actually came out right around the same time as the meeting, was able to show that with bariatric surgery, we can actually prevent adverse liver outcomes. And they did this biopsying patients who were undergoing bariatric surgery and then comparing it to non-surgical controls over time. Next. And to take that further, what was especially interested in about this study was they were able to show that with bariatric surgery in patients with NASH, you could reduce major adverse cardiovascular endpoints, which is so important. You know, in our NASH patients, as a hepatologist, I always worry about liver disease, but I have to remind myself that actually cardiovascular disease is the #1 cause of death in these patients. So if we can treat multiple issues that are going to affect their morbidity and mortality, that's going to be key. So bariatric surgery, more data just to support its use. Next. So just to go back to the guidelines for a second in terms of talking about pharmacotherapy, across the board, again, the guidelines have recommended that we reserve pharmacotherapy for patients with NASH and fibrosis. So although, you know, there are many different treatments available, those are the patients that we want to identify, and the dietary and other lifestyle things that we discussed, those with patients without fibrosis, we should continue to recommend those. Next slide. So in terms of pharmacologic agents, this has been a very busy field. Anybody here is, you know, any journal you look at right now, they're talking about a new agent, I'm sure. But I wanted to highlight the few that you can see here in red that I recently discussed at the meeting and around the same time. So let's go into those just to update you on data that we have available. Next. Well, I first want to talk about semaglutide. A lot of talk about this at the meeting. We all know about the New England Journal of Medicine article that in the phase 2 trial of this compound that showed significant improvement in NASH with high dose semaglutide. So a lot of excitement, and there's an ongoing phase 3 trial. Next. And although this study did not show significant improvement in fibrosis, it did show that it helps to prevent fibrosis progression. So patients treated with this compound appear to at least have stability and did not progress at what we would see in a normal placebo group, as you can see here. And again, it seems to be a dose-related effect. Next. What we did learn at the meeting, though, which I think many of us have asked ourselves, okay, well, the semaglutide only work because it helps people lose weight. We know that's one of the powerful effects with this medication. And that's a big part of it, probably about 72% of the effect. But looking at this data, it appears that there is something intrinsic to semaglutide, and that, you know, the GLP-1 agonist that also affects the liver and helps to reverse NASH. So again, a promising treatment that I think we're going to be seeing a lot more of. Next. Now, things from there aren't all as happy. Unfortunately, we also saw a lot of compounds determine that they're not going to move forward. Unfortunately, things that we had been really hopeful about. One of those was pegbelfermin, which is FGF21. This compound, this specific study was a phase 2 looking at patients with stage 3 or 4 fibrosis. And unfortunately, they did not meet their endpoint and have decided to stop this program in terms of studying NASH. Next. Similar story with adafermin. This is FGF21. Really positive early data that we saw in terms of significant hepatic steatosis improvement, but did not meet the endpoint needed in the study, and they decided not to move forward. Next. But still, there's some excitement. The lanfibranor, which is a PPAR agonist, so similar to pioglitazone, which were all available, but difference here is that this is a pan-PPAR agonist, which pioglitazone only acts on specific PPARs. This very exciting study, 247 patients, was able to show at the high dose of this compound, as you can see here, really significant improvement in NASH in 55%. So this is going forward in phase 3 trial, and hopefully we'll be seeing more at future meetings with overall good safety. Next. And another compound that we're going to be hearing more about, resmetirom. This is a thyroid hormone receptor beta agonist, which I think is fascinating. We've learned recently that there are thyroid receptors on the liver, specific ones that may be cause NASH or can lead to NASH occurring. And this compound has shown a lot of promise. What's been interesting with this study as well is that although they are doing liver biopsies, they've used non-invasive tools like MR elastography, where you can combine it with MR PDFF, proton density fat fraction, and shown, as you can see here in the high dose, almost 50% reduction in hepatic steatosis. The phase 3 trial is ongoing. Next slide. And we just received this press release. You may have seen this in your email January 31st, that they presented some top line results from the phase 3 trial showing significant improvement in hepatic steatosis so far, what they've seen, and also some key measures in cardiovascular health, which again is really important to us and our patients with NASH. So a significant improvement here in terms of triglycerides. So an exciting compound, and hopefully we'll be seeing more things as it moves towards FDA approval, I think, in the next year or so. Next slide. You can see that the key here really is combination therapy. No one agent is perfect. No one agent is going to wipe out everyone's NASH or reverse it. But if we can combine these different therapies with different mechanisms, potentially we could get even greater effect. And I have an example here of a phase 2b trial that is ongoing. We're still learning more about these things, but I think that's going to be the key to the future of NASH. Next slide. So just some take-home points. NASH is a common progressive disorder with increasing prevalence that can lead to cirrhosis, hepatocellular carcinoma, liver failure. Use of combinations of serum biomarkers and imaging has been shown to significantly improve our diagnostic accuracy and potentially can be used for disease monitoring, and hopefully we can prevent the need for liver biopsies in the future. And future therapies show promise. Next slide. Thank you for your time. And if you have any questions, please feel free to reach out to me.
I don't see any questions in the chat box yet, but I have one. Dr. Halegua, you'd started off talking about non-invasive markers of fibrosis. Do you personally have a preferred combination that you use in your practice now? And where do you still see a role for liver biopsy?
Yeah, great question. I really like the non-invasive tools like the FIB4. It's so easy. We can calculate that while we're seeing patients instead of, spending more money on the FibroSures and which don't have great accuracy, unfortunately. And I love elastography. Honestly, every patient I'm seeing with fatty liver needs to get elastography, and especially things like FibroScan. They're so inexpensive if you have one accessible. And if you can combine it with an ultrasound, it's really a great tool. A few pitfalls with that, though. Definitely in our obese patients, be careful with elastography, especially when BMI is over 35. Sometimes the accuracy can be affected. So I'm using a combination. I'm starting to use the FAST score that I mentioned. That one's very easy to calculate. And the ELF score, I didn't get a chance to dig into that, but everybody may know that just got FDA approval. It's not easy to order yet, so I'm still working on how to integrate that in my process, my practice, but that's going to be very exciting, specifically for diagnosing those advanced fibrosis patients.
Thank you. Thank you very much. It's now my honor to introduce our next speaker. Certified by the American Board of Surgery, Dr. Lorenzo Machado is a highly skilled transplant surgeon who specializes in liver transplantation, hepatobiliary surgery, and minimally invasive laparoscopic liver surgery. Dr. Machado earned his medical degree at the University of California, San Francisco, completed his surgical residency at Maricopa Medical Center in Phoenix, Arizona. Then he received additional training in abdominal transplant surgery during his fellowship at the University of Cincinnati. He is a member of the American Society of Transplant Surgeons, American College of Surgeons, and the American Medical Society. And he also works as an instructor for advanced trauma life support. Dr. Machado.
Oh, Mike, thank you. Next slide, please. Next slide. You can skip this one. We'll just get to the overview. Thank you for having me. And tonight I want to discuss some recent changes that have occurred over the last few years regarding the organ allocation system and the impact that that's had on liver transplant candidates. And also for us as the treatment team, that we've had to use more organs or organs that are considered extended criteria organs, in particular donation after cardiac death donors and marginal donors. And I'll touch base on what this means, but also going to discuss a little bit about living donor liver transplantation, as this is a program that we recently started at Allegheny General. Next, please. So the traditional way, or the way that the organ allocation system worked, and many of you have probably seen maps like this, is that the country was divided into regions. And as you can see, the map on the screen left, Pennsylvania is shaded in this gray, along with West Virginia and New Jersey. And this entire area is called Region 2. The organs were first shared locally. And the map on the right, you can see that the western half of Pennsylvania is light blue, along with West Virginia. That is divided into what's called the donor service area. And that area, and these donor service areas, as you see the map on the right, the entire country is divided into these. And it looks almost like a congressional map. It doesn't actually make sense how these donor service areas were actually created. They were historical, but each donor service area is served by a organ procurement organization. In our western half of PA, West Virginia, that is the Center for Organ Recovery and Education, or CORE. And the idea was to keep organs first locally, or offer them locally to patients within that donor service area. And then regionally, which meant the entire state of PA, New Jersey, and West Virginia. And lastly, nationally. Well, that created some disparities, especially on the coast, in particular the East Coast and the West Coast, where the higher population centers are located, and median MELD scores really were driven up, or were going up in these urban centers. MELD scores in the high 30s were sort of the median scores that were used in New York and LA. And down in the South, you had centers with median MELD scores in the low 20s. So that this disparity was been fought over as to how do we make the allocation system a little bit more fair, or more sharing for everyone. And you can go to the next slide, please. And so then that brought about in the last few years something called acuity circles, where the allocation is no longer based on these donor service areas or regions, but it's actually based on where the donor is actually located, i.e. the donor hospital. And there's, as you can see in the diagram below, there's circles around what's supposed to be the donor hospital. And the distance from the donor hospital is 150 nautical miles, 250 nautical miles, or 500 nautical miles. And based on the location of the recipient center, that's how the organ is allocated, or that's where the priority is set for patients. But it also takes into account whether this donor is a donation after brain death, or a donation after cardiac death, where DCD donors are considered more marginal. So they tend to be allocated more locally. It's based also on the donor age, with younger donors being more widely shared, as opposed to donors who are greater than age 70 tend to stay more local. But it's also based on the recipient MELD score. a higher MELD score, it's shared more broadly. Also, pediatric patients will get more priorities. Next slide, please. So the idea with these acuity circles was to even out the median MELD score throughout, and we'll see in the coming years what that does. And at Allegheny General, our median MELD score is around a 26, 27. And the idea is, well, everyone should be closer to somewhere around a 28, 30, both East Coast, Midwest, West Coast. But what that does is it's going to drive the MELD score or the median MELD score for recipients a little higher. So what is that going to do to the lower MELD patients? What is that going to do for patients who are MELD scores 15 to 25, who technically are not getting offers, but may be very sick? They have ascites that requires paracentesis every couple of weeks. Their life is fairly miserable, that they spend all their time going from one paracentesis to the next, almost like dialysis patients. But these donors, then we started to, the idea is, well, how do we get these recipients transplanted? And this is where this idea of marginal donors comes in. Can we start using livers that are quote unquote marginal? And I put it in quotes because these still are very good livers. Sometimes as surgeons, we use these words marginal, and our medical colleagues, I can see the look on their faces. They think we're giving someone a bad organ. It is really just a risk-benefit ratio. And I'll go into a little more into what that means, but we're talking about, would I want to transplant everyone with a 25-year-old low BMI, perfect liver? Of course, but the reality is we don't have many of those organs. So we have to look at donation after cardiac death, older donors, donors with increased steatosis. And from the last talk, as you guys can see, this is becoming an increasing problem. So as more patients, or as our society gets bigger, we're going to have to start to look at how can we use these organs that historically have been discarded. And the last is, do we consider doing living donors? This graph on the right shows the experience of the DCD donors, or the DCDs, over the last 20, 25 years or so. And as you can see, it's been increasing, and especially in the last 10 years or so, it's increasing significantly. Next slide, please. This is actually the entire liver transplant experience. And the bars in blue are deceased donors, both brain dead and DCDs. The bar in red represents living donors. And from its inception, liver transplant, the number of liver transplants that we have been doing has also been increasing. And last year was the first time total as a country we passed 9,000 liver transplants in a year. However, although the part of that in red is getting a little bit larger, as you can see, the living donor recipients have doubled from 10, 15 years ago. It still only makes up about 5% of the total. So living donors in this country is still a very, very small percentage. Next slide, please. So when we talk about deceased donors, really we're talking about donation after brain death and donation after cardiac death. For those of you who don't know or have not been in the operating room with us when we do a procurement, just going to go through these timelines because it's going to matter a little bit, the explanation of where we can make some changes. So these timelines were actually made for heart transplant patients, but wherever you see heart, you can just go to put in liver and it's the same. A brain dead donor has been declared brain dead. When we bring them to the operating room to do the procurement, they are intubated and they have essentially normal cardiac function. So the organs are being perfused. And the goal of the procurement is to essentially exchange the donor blood for preservation solution, cold preservation solution, in order to preserve the organ, package it, bring it to the transplant hospital. So this cold preservation solution, although the organ is kept at 4 degrees and the metabolic activity of the cells is much less, there is still a lysis that is occurring. There is still injury that is going on. And we see this at the time of transplant where we have a ischemia reperfusion injury. For brain dead donors that are young, that is many times negligible and organ starts to work right away. This is different in the donation after cardiac death, in that when the donor is brought down into the operating room area, first life support is withdrawn. So they are extubated. If they're on pressors, those are stopped. And there's a period of time where we have to wait for the patient to become asystolic. Once they reach circulatory arrest, there's a wait period, this standoff period that is in this timeline before they are declared actually deceased. And that standoff time is between 2 to 5 minutes. After they're actually declared deceased, then we can start the procurement. So as you can see in this middle timeline, there's a whole lot of time that these organs are having some injury or some hypoxic stress that is going on. And then we put the organ into cold preservation solution. The last timeline, I'll get into it a little bit later. Next slide, please. The picture up on the left is actually a liver that is being procured. There's just that's a ruler to sort of give it the recipient surgeon an idea of how the size of the liver. So this is a liver that is perfused in the body. And the picture on the right is a liver that all the blood essentially has been drained and replaced by preservation solution. This pale looking liver, to me, it's a beautiful liver. To some, it may look pale, but nonetheless, this cold storage, this liver is going to be put into a bag with cold storage solution and then brought to the transplant center and transplanted. So one of the ideas is, can we make a difference in this cold storage? Can we improve the cold storage so we can have better outcomes and less discard of organs? Next slide, please. So one of the ways to do that is to actually do normothermic machine perfusion. This picture there, what you're seeing is an organ that has been removed. So it had the cold perfusion, it looked pale, and then it was connected to this machine that is essentially running oxygenated blood with nutrients through it. And the idea is, can we make assessments of these livers, and in particular, look at the lactate level, look at the bile production of the liver, and see, is this a usable organ or not? Also, we can actually increase the amount of time that the liver is outside of the patient's or the donor body, or the time between when it's taken out of the donor to when it's reperfused in the recipient, this warm ischemia time. Usually, most centers will target a time of trying to get a liver in within 8 hours. but really you want to get it in as soon as possible, 5 to 6 hours. But if you can keep this organ on a machine with being oxygenated, can you keep it for longer? i.e., can you travel to California to procure a liver, put it on a plane for 5 hours and still have time to do the recipient surgery? This graph on the bottom right here, this is a study looking at this machine perfusion. This was a study called the PROTECT trial, looking at this particular machine. There's several different companies making them. This is a Transmedic machine. But as you can see, as the organs that are being transplanted or that were transplanted had a decrease in the lactate levels that could be followed and were followed while the organ was on the machine. So the organs that where the lactate level didn't decrease, these were discarded. And this is a way to take an organ that has, it's maybe more steatotic and make a real assessment of it. Will it function in the donor? What are the chances of having problems with it once it's reperfused and in the recipient? Next slide, please. So they also looked at what's called early allograft dysfunction. And for any of you guys who treat liver transplant patients, you'll know that early allograft dysfunction can lead to many, can lead to a longer hospital stay. Patients can have bleeding, longer ICU stays. And this, when the organs were placed on this machine, they were noted to have less early allograft dysfunction. The graph on the top right shows that they had less moderate to severe lobular inflammation, which is a marker for reperfusion injury. And most importantly, these organs also had less ischemic cholangiopathy, which for any liver transplant surgeon, this is could be a terrible outcome for our patients. Next slide, please. But one of the biggest thing, if you look at the graph on the right, top right, the utilization rate, especially for the DCD organs, was much higher, double the utilization rate. This was still a small study, a small group of patients, but very, very promising. And in the last graph down at the bottom, outcomes were similar, one-year outcomes. Next slide. So if we can make some changes on the static cold perfusion side, can we do something during the procurement part to decrease and make an assessment for a donor who's undergoing this hypoxic injury during the DCD procurement? Next. Well, this idea of normothermic regional perfusion is to put patients who have undergone who are DCD patients and really rewarm them and re-provide oxygenated blood. And you do this through ECMO cannulation. So instead of putting cannulas and putting cold perfusion through, we actually put blood through, or we run the blood, and then we can make assessments just like with the organ that was ex vivo. We can make assessments of the lactate level. We can make assessments of bioproduction. Next slide, please. And this is just graphs showing livers that were used, and specifically the lactate level. More importantly, the ones that were used, you can see the lactate level decreasing. The ones that weren't used, and this is new technology for those of us. So even some of these organs potentially could have been used. But if the lactate level didn't decrease significantly, these were not used. Next slide. And much like with the ex vivo machine perfusion, the utilization rate also doubled, or essentially doubled. These guys had no ischemic cholangiopathy and equivalent one-year survival rates. So very promising. We don't have either of these technologies here in our area, but we are in the process of developing that, hopefully in the coming months. Next slide. And just the last couple of slides touch base on living donor liver transplantation. Because some of these donors are waiting a little bit longer to have a deceased donor transplant, living donor liver transplant is an option to try to get these patients transplanted faster, these lower MEL patients. But we're always weighing the donor risk versus the recipient benefits. These have to do with how much future liver remnant is going to be left in the donor, how much liver are we giving to the recipient, and what is the actual anatomy. Next slide, please. This is the different types of graft that can be used in the liver. The left lateral segment composes about 15 to 25%. That's usually used for when an adult is donating to a child. A left lobe can be used for a smaller adult or a larger child recipient, but most programs use a right lobe, which is about 60 to 70% of the total volume of the liver. So you can see where we really have to make accurate assessments. We have to evaluate the CT scans, do three-dimensional imaging in order to get a very good assessment of how much liver are we removing, but more importantly, how much are we leaving behind? Because the last thing we want to do is for one of our donors to go into liver failure. Next slide, please. So with living donors, the mortality is still remains very, very low. I wish that mortality was zero, and it should be zero. They still do have complications, most commonly biliary complications, whether that's a biliary a leak or a stricture. Most are managed non-surgically, usually with an ERCP and stenting. Wound infections and hernias are the other most common complications. And 1 year survival for the recipient of a living donor is very similar to a deceased donor liver transplantation. And the more experience we gain with living donor liver transplants, the higher this number will go. Next slide, please. I think that is all. I'll take any questions.
Thank you very much. I think that, first off, it's impressive to see 9,000 transplants. I mean, for a long time, we were sort of stuck at that 5,800, 6,000 number. And in the year of the pandemic, is the second year of the pandemic. So that's really exciting. But I think that what you really told us, Dr. Machado, was it's not really a question. I'm just saying that it's only going to get more. Like there's only going to be more options. So, good luck, transplant surgeons. You guys don't get much sleep.
Well, I like that we're having definitely more. The thing that we're finding is that our donors, much like the rest of the population, is becoming sicker, right? More comorbidities. So we're finding, how do we work around that? And that's what these technologies are trying to do. How do we work around having not just sicker recipients, but sicker donors?
Sicker donors. Excellent. Well, thank you so much for that excellent talk. And I loved your initial comment about how the map looked like the not electoral.
The congressional district.
Congressional. Yeah, you're right. It doesn't make much sense. Thank you. Okay, well, it's my pleasure, my absolute pleasure, to introduce our next speaker, Dr. Ranjita Bahrwani, who is going to be speaking on the overview of the Baveno guidelines for portal hypertension. So Dr. Bahrwani is a fellowship trained and board certified transplant hepatology, gastroenterology, and internal medicine. Her professional interests include management of patients with end-stage liver disease, liver transplant, and HCC. Dr. Bahrwani is a committed educator, and I know that firsthand, having spent many years with her at the University of Pennsylvania when she used to work there. Is a committed educator and currently serves as an associate program director for the Department of Internal Medicine at Baylor University Medical Center, part of Baylor Scott and White Health. She attended medical school at Northwestern University, Feinberg School of Medicine in Chicago, and her internship, residency, and fellowships in gastroenterology and transplant hepatology all took place at the hospital of the University of Pennsylvania. She joined faculty and staff of Liver Consults of Texas at Baylor in 2016. I'm very excited to see her, as I have not seen her in quite a few years now because ASLD has been virtual, but it's nice to see my good friend, Dr. Bhawani.
Thank you so very much. I hope you guys can see and hear me okay.
We can hear you and not see you yet, but we can hear you.
Oh, that's a problem. So interestingly, I think the internet here down south leaves much to be desired because I'm online and my video should appear, but I promise I'm here in the flesh. I hope it shows up. Out of respect of everybody's time, I will go on, but please let me know if you have any issues with hearing me. I hope this works as expected.
Yep, we hear you fine.
Perfect. And thank you so very much for the opportunity. I'm delighted to spend time with you virtually. I am no longer in Philadelphia, but I miss you all dearly. And thank you, Dr. Kroc, for the kind invitation. I am in many ways a reflection of you because you contributed hugely to my training, and I'll always be grateful. So without further ado, I'd like to start off. I have been tasked with discussing an overview of the Baveno guidelines for portal hypertension. This is hopefully not going to be a 20-minute talk because I have a very specific task at hand. So hopefully we'll have enough time for questions on the back end. Next slide. So this should come as no surprise to you all. Portal hypertension is reflective of both the static component with increased resistance to blood flow in a liver that has scar once it develops cirrhosis, as well as a dynamic component mediated by nitric oxide with splanchnic vasodilation, increased portal flow, worsening portal hypertension, and an immediate result of that is collateralization and the development of varices. Next slide. So the prognosis in cirrhosis does indeed depend on whether you're compensated or decompensated. So in compensated cirrhosis, the median survival is well over a decade, the survival being slightly lower in those who develop varices, hence clinically significant portal hypertension, as I'll discuss in the next few slides, vis-a-vis those with decompensated cirrhosis, namely variceal hemorrhage, ascites, encephalopathy, in whom the median survival is give or take 2 years. And these are the patients in whom you really need to think about liver transplant. Next slide. So we tend to meet patients along the spectrum of liver disease. When patients come in the hospital, by then they've already developed decompensation in the vast majority of patients with variceal bleeding, ascites, encephalopathy. Oftentimes they do have superimposed infections and then develop this very ominous acute on chronic liver failure, which has a high mortality. And I won't talk about that in any more detail here. But a lot of the patients that we see in the clinic oftentimes present earlier on in the course, and they may or may not have stigmata of portal hypertension. And what can we do to risk stratify these patients early on to determine which patients are going to go on to progress and develop decompensation and have complications? Next slide. So how do we define portal hypertension? It is defined by the hepatic venous pressure gradient. And as you know, this is measured via the transjugular route by placing a catheter in the hepatic vein and calculating the gradient by measuring a wedged hepatic vein pressure, which is measured by inflating a balloon in the hepatic vein, and then taking a free hepatic vein pressure, which is measuring the pressure with the balloon deflated. And the difference between the two is the hepatic venous pressure gradient and reflects the sinusoidal pressure. And this is what defines portal hypertension. So in patients who have a hepatic venous pressure gradient under 5 have no portal hypertension. Those with a gradient between 5 and 10 have mild portal hypertension. Those who have a gradient of 10 or more have clinically significant portal hypertension. And then in those with a gradient of 12 or higher have a risk of decompensation and worsening bleeding with varices. Next slide. So this is a really, really powerful tool with regards to predicting decompensation in patients who start off with compensated cirrhosis. And as you can see on this graph, in those who have mild portal hypertension, vis-a-vis those who have what we call clinically significant portal hypertension defined by an HVPG of 10 or more, you can see that the risk of decompensation, namely ascites, variceal bleeding, and hepatic encephalopathy, increases by almost 4-fold. Interestingly, this also is predictive of hepatocellular carcinoma. Next slide. And so when we think about portal hypertension, it's important to think about complications on a continuum of the hepatic venous pressure gradient. The threshold of 10 being that defines varices formation and also what we call clinically significant portal hypertension. And this also increases the risk of decompensation, including hepatocellular carcinoma, as discussed on the previous slide, and also increases risk of complications after surgery. The threshold of 12 is what increases risk of bleeding with varices. A risk threshold of 16 increases hepatic mortality, and then 20 has what traditionally been used for to classify treatment failure and mortality in patients with acute variceal bleeding and the patients that should be fast-tracked to TIPS. Next slide. So thinking about cirrhosis, again, in the compensated stage, based on the hepatic venous pressure gradient, patients can have mild or clinically significant portal hypertension as defined by a hepatic venous pressure gradient of 10 or more. And if the gradient is less than 10, these patients do not have varices. If it's over 10, they may or may not have varices. And these patients classically have no complications associated with liver disease. And here's where we can actually use primary prevention and try to risk stratify these patients to see which are the patients that are going to proceed to develop decompensated liver disease, namely ascites, encephalopathy, variceal hemorrhage, etc. And those are the patients, like I said before, you want to stratify for transplant. Next slide. And so looking at it with regards to numbers with mortality in the compensated stage, and this is what we refer to as the D'Amico criteria, patients are defined as stage 1 if they are compensated with no varices, and these patients, no surprises, have a very low risk of mortality at approximately 1% a year. Those who develop varices are classified as stage 2, but still compensated. These people have clinically significant portal hypertension, and they have a slightly increased mortality with a 1-year risk of about 3% or so. And then those developing decompensated cirrhosis have increased mortality, stage 3 being those with ascites, with or without the presence of varices, entailing a 1-year mortality of 20%. And those with variceal bleeding, with or without ascites, have a much higher risk of decompensation and mortality, upwards of 60%, and those are stage 4. Next slide. So what about non-invasive testing, and how can we use non-invasive testing measuring liver stiffness as a surrogate for fibrosis to risk stratify patients along the continuum of portal hypertension? Next slide. So there are multiple ways that liver stiffness can be measured. Most frequently, vibration controlled transient elastography, but some places, including here at Baylor where I practice, two-dimensional shear wave elastography or ultrasound elastography. And the new kid on the block that is not available uniformly and also not easy to get insurance approved, but definitely a better quality study is MR elastography. And all of these essentially measure liver stiffness as a surrogate for fibrosis non-invasively. Next slide. And these perform really, really well, looking at sensitivity, specificity, positive predictive value, and negative predictive value as you're comparing different imaging modalities, that is vibration-controlled transient elastography, using a medium or XL probe, depending on how obese the patient is, vis-a-vis shear wave elastography and MRE. You can see that these really have, their power is in the negative predictive value, which is well over 95%, irrespective of what modality that you use. So these are very good in ruling out significant fibrosis. Next slide. And so this is probably the most important slide of the talk that I'd like you to take away today is how can we use non-invasive testing to determine what patients' risks are of clinically significant portal hypertension, namely varices. So in patients who have newly diagnosed liver disease, the first question is, do they have compensated liver disease or not? And by that, I mean, do they have ascites, encephalopathy, or variceal hemorrhage? And if they do, then they are decompensated, so then they need an annual endoscopy. But if they are compensated, on the left-hand side, the big question to ask is, do they have clinically significant portal hypertension or not? And how do you determine that? This is when non-invasive testing can actually be really helpful. If patients have a liver stiffness that is less than 20 kilopascals and their platelet count is over 150,000, they meet criteria where they do not have high-risk varices statistically. And so in these patients, you do not need annual endoscopy. And I'll share with you data from the Baveno guidelines that say that assuming that patients with cirrhosis have a prevalence all around of high-risk varices of 20%. And by high-risk varices, I mean varices that would need endoscopic intervention. If you were to follow these guidelines and say that patients with a liver stiffness of less than 20 kilopascals and a platelet count over 150 do not need endoscopy, you would save 26% of patients needing endoscopy and miss high-risk varices in only 2% of patients. So think about the cost effectiveness of that using this. And this is really the takeaway point from this talk. Next slide. And the reason this is important is that, of course, endoscopy does come with risks associated with the procedure, including perforation and aspiration, as well as risks associated with sedation, whether it is moderate sedation that you are administering or your anesthesiologist who are on site. Cost, we know that the cost of an upper endoscopy, including the cost of your overhead as well as your anesthesia costs, is at least 4 times higher than the cost of a non-invasive test, be it shear wave elastography or a VCTE. Accessibility, I will say that over the last decade, non-invasive measures have become much more easily accessible. We now even have it in our hospital for inpatients to be able to measure fibrosis. And really, this is really helpful to be able to risk stratify patients, because we know that per recent data, less than half of patients with liver disease actually have access to endoscopy for variceal screening and surveillance. So we really don't do a great job at all. And if we can save patients endoscopy that is unneeded, that would be helpful. And as I shared with you earlier, and I'll show you some more data, indeed, this is effective. It is helpful to use non-invasive testing to identify those who are at low risk for varices and hence can skip the endoscopy. Next slide. So what do I mean by high-risk varices? This is just a little show and tell. On the left, you can see small varices with no high-risk stigmata, namely no red whale signs or white nipple signs. And on the right, you can see big juicy varices, and you can see the arrow pointing to a white nipple sign. So this would be a high-risk varix needing endoscopic intervention. Next slide. So what about non-invasive tests for variceal screening and how they do? So looking at the Baveno 6 criteria, looking at vibration-controlled transient elastography, as previously mentioned, using a cutoff of liver stiffness of less than 20 kilopascals and a platelet count of over 150,000, the pooled sensitivity for ruling out high-risk varices was 0.97. And what this means is you can spare 26% endoscopies, as you can see on the slide, and you will miss high-risk varices in only 2% of people. Now, expanding the Baveno criteria, increasing the liver stiffness threshold to less than 25 kilopascals and the platelet count to over 110,000, the sensitivity does go down. You spare more endoscopies, up to 43%. However, you miss a slightly higher number of the high-risk varices, namely 5%. And so where is your happiness threshold is the question. And so indeed, if you keep conservative with the stiffness threshold of less than 20 and the platelet count of over 150, you really spare up to a quarter endoscopies, and you miss high-risk varices in only 2%. Next slide. One more time. Thank you. So I wanted to spend the last few minutes talking about the expanded criteria, the new Baveno 7 criteria in portal hypertension and what's new. And these are actually just published earlier this year. So hopefully we'll share something new that you might find helpful in your practice. Next slide. So in the Baveno 7, they focused a lot about using elastography in clinical practice to find patients with chronic liver disease who are at higher risk of having clinically significant portal hypertension and hence are at risk for decompensation and liver-related death. And so this new term, coined compensated advanced chronic liver disease, has been proposed to reflect the continuum of fibrosis and cirrhosis in those with ongoing chronic liver disease. And the whole point of this was to have a pragmatic definition of compensated advanced chronic liver disease based on liver stiffness measurement and aiming at stratifying patients with the risk of clinically significant portal hypertension and hence subsequent decompensation. Next slide. So in patients who have liver stiffness measures by transient elastography of less than 10 kilopascals without known clinical or imaging signs, ruling out compensated advanced chronic liver disease, less than 10 is plenty, you've ruled it out. In those who've had values between 10 and 15, those are suggestive of compensated advanced chronic liver disease. And then those who have a transient elastography liver stiffness score of over 15 are highly suggestive of compensated advanced chronic liver disease. And in those who have a liver stiffness measure of less than 10, their 3-year risk of decompensation and liver-related death is negligible at less than or equal to 1%. So that threshold of 10 kilopascals should hopefully give you ease that these patients are not going to progress to decompensated liver disease or clinically significant portal hypertension. Next slide. And so this is a nice framework to keep in mind, which is the rule of 5 as suggested by Baveno 7, which is that if you have a liver stiffness of less than 10 kilopascals, you are ruling out compensated advanced chronic liver disease. 10 to 15 is the gray zone where you may or may not have compensated advanced chronic liver disease, but you can be comfortable that if someone has a liver stiffness of less than 15 and their platelet count is over 150, they definitely do not have clinically significant portal hypertension. If they have a liver stiffness less than 20 and their platelet count is over 150, you can avoid endoscopy based on the Baveno 6 criteria. And then, of course, the higher the liver stiffness over 20 and particularly over 25, you definitely have compensated advanced chronic liver disease and you're at higher risk for decompensation. Next slide. And so even though clinically significant portal hypertension, as I shared with you a couple slides ago, is hepatic venous pressure gradient driven with that threshold of 10 as we discussed, non-invasive tests are sufficient per Baveno 7 and they're accurate to identify clinically significant portal hypertension in clinical practice. So once again, if by transient elastography, your liver stiffness is less than or equal to 15 and your platelet count is 150 or higher, you are ruling out clinically significant portal hypertension with a sensitivity and negative predictive value of over 90%. So you can feel pretty good about these numbers. And the Baveno 6 criteria are good for looking for endoscopy with high-risk varices, i.e. your liver stiffness measure of less than 20 and platelet count of over 150 can be used to rule out high-risk varices. And so here this is safe, cost-effective, hopefully accessible, and indeed effective. And like we said, you're only going to miss 2% of high-risk varices if you stick to these thresholds. Next slide. So in those patients who have liver stiffness values of between 7 and 10, so again, they're less than 10, so they do not have compensated advanced chronic liver disease. If they have ongoing liver injury, i.e. ongoing alcohol use, untreated hepatitis C, insufficient weight loss in non-alcoholic fatty liver disease, these patients should be monitored for changes indicating progression. And in those who have compensated advanced chronic liver disease, you want to repeat the liver stiffness measure every year. And a clinically significant decrease in liver stiffness measures, which is associated with a substantially reduced risk of decompensation and liver-related death, is defined as a drop in 20% or more associated with that threshold of 20 for liver stiffness, or otherwise any decrease in liver stiffness to less than 10. So if you have a 20% drop associated with a less than 20 in your absolute measure of the liver stiffness, you've actually had a significant decrease clinically, or if you actually meet that threshold of 10, at which point you do not have compensated advanced chronic liver disease. Next slide. So patients avoiding screening endoscopy can be followed with yearly transient elastography and platelet count assessment. And if the liver stiffness increases to 20 or more, or the platelet count declines to under 150, that's when screening endoscopy is indicated. And in the absence of cofactors, a special mention for hepatitis C was in the Baveno 7, that in those who have hepatitis C-induced compensated advanced chronic liver disease, who subsequently achieved a sustained virologic response, hence have been cured, and show improvement in liver stiffness measure to less than 12 and platelet count of over 50. So this is a special criteria for Hep C only, can be discharged from portal hypertensive surveillance because they have negligible risk of hepatic decompensation. So with Hep C, the threshold is not 15 and 150, but 12 and 150. However, given the risk of liver cancer, even in those with stage 3 fibrosis with hepatitis C, HCC surveillance should continue in these patients, irrespective of that threshold for liver stiffness measure per Baveno. Next slide. And so I just wanted to put this slide up because this was just published in the Journal of Hepatology, looking at risk stratification of decompensation using these criteria of liver stiffness and platelet counts in patients with compensated advanced chronic liver disease. And so when you look at the patient's grades based on liver stiffness measures, grade 3 being liver stiffness of 25 or higher, grade 2 being liver stiffness of 20 to 25, and then grade 0 and 1 being a liver stiffness of less than 20, but 0 associated with a platelet count of 150 50 and higher, and 1 being a platelet count less than 150. When you look in the graph on the right, looking at the cumulative incidence of liver decompensation vis-a-vis time, what is fascinating is that even when you look at the grade 0 to grade 1 patients, which by the way, both of those have a liver stiffness of less than 20, but grade 0 has a platelet count of over 150 and grade 1 has a platelet count of less than 150, you can see that having grade 1, i.e. a drop in your platelet count, is associated with almost a 10-fold increase in hazard ratio for liver decompensation. So it's important to make sure that when you're looking at the liver stiffness measure, you want to look at that in conjunction with the platelet count. And so the table at the bottom is a nice one to try to think about this in clinical context. So in patients who have compensated advanced chronic liver disease, i.e. they have met that threshold of 15. If their liver stiffness is less than 25, if their liver stiffness is not less than 25, they're at high risk, i.e. they're the grade 3. If their liver stiffness is less than 25, are they less than 20? If not, they are grade 2, so they're medium risk for decompensation. If their liver stiffness is less than 20 and their platelet count is over 150, those are the low risk patients for decompensation that you can feel good about saying we don't need to worry about an endoscopy. But if their platelet count is still low, despite having the liver stiffness measure of less than 20, they are still considered medium risk. And so in those patients, you do want to proceed with an upper endoscopy, and they do have a higher risk of decompensation. Next slide. And so this is really my final slide before I'll take any questions, to remind you that in those with compensated liver disease, non-invasive testing is really, really helpful to determine what patients have clinically significant portal hypertension or not. And do remember, with regards to criteria for endoscopy, if you have a liver stiffness less than 20 kilopascals and your platelet count is over 150, you can defer endoscopy and repeat non-invasive testing annually. And then, you know, I do believe that the Baveno 7 criteria, which looks at the transient elastography stiffness measures on a continuum, are probably going to come more into clinical practice. But the big takeaway for right now is please do use these thresholds to determine need for endoscopy or lack thereof, as this really will not hurt your patients and save a lot of patients from endoscopy. Thank you so much, and I'll gladly take any questions.
Thank you so much. You know, I feel like we, these guidelines came out and I know that we know about them, but I don't think that we're using them so much in clinical practice. I thought it was interesting, Dr. Bharwani, when you mentioned, you know, that 50% of patients don't have access to upper endoscopies, I think you said. Is that what you said?
Yes, that is exactly what I said. So
I would imagine that there's a higher percentage that won't have access to elastography.
And it's funny that you said that, because my concern was always that with regards to how it was available, but honestly, it's become much more available now. I'm often amazed. So I practice in Dallas, but I will tell you, I have patients that come within a 5-hour radius in Texas, and they can get elastography in small imaging centers. And I'm always pleasantly surprised. It is not that expensive and much more accessible than I thought it was.
Well, yes, I think it is becoming more and more accessible, which is excellent. Dr. Machado.
So I have a question for you in that I'm one of the transplant surgeons, and one of the things that we struggle with in compensated cirrhosis is surgery in these guys. And specific examples that come up is a patient who has both cirrhosis and end-stage renal disease, but their cirrhosis is compensated. Can we do a kidney alone transplant on these guys? And how do we determine that? Most of the time on these patients, we end up getting invasive testing. But has any of these non-invasive tests been used for something like that? And I don't know if we are ready to be the first to start doing non-invasive testing. Maybe we're a little too chicken to go that route. But have any of these non-invasive tests been evaluated in that setting?
They have, and the teaching is that they're sensitive, not specific, because remember, in the setting of volume overload and hepatic congestion, the tests can be falsely elevated. So we use them in end-stage renal disease, and they're great at ruling out significant liver disease. Now, without taking too much time, it becomes nuanced in retroperitoneal surgery, right? In that, in somebody who has cirrhosis, if they do not have clinically significant portal hypertension and their gradient is less than 10, or they don't have varices, they can get a kidney transplant even if they have cirrhosis. That's our criteria. Right. That's what's recommended nationally. And so the question then becomes, how good is transient elastography in that zone? And that has not yet been studied because of the inherent limitations of volume overload and hepatic congestion with regards to accurately predicting that. So if you have a low liver stiffness, you're good. The problem is when the liver stiffness is high, how high makes it uncomfortable because of the limitations of the study in the setting of congestion. I hope that answers your question. And I don't know if Karen Kroc has any comments in that regard, but that's the limitation with using it in this specific population.
All right, thank you.
You're welcome.
I think we heard from both Dina and Ranjita that every person with fatty liver disease and everyone with cirrhosis needs an annual fiber scan. So I think we should be, probably buying into fiber scans more.
Absolutely. Absolutely. It's much more accessible than you think. Please.
Yes. Excellent. Thank you so much, Jill.
Thank you again, Dr. Marijuana, for your talk. I appreciate it. We are on to our short break that we'll have this evening. Please take this time to visit the sponsors through our CVent application on your phone or online. In addition, our sponsors would just like to present their themselves, their company, and their product. We'll begin with AbbVie, and we have Julene Vidic from AbbVie.
Julene Vidic. You did that very well, Jill.
Thank you so much, and please tell us more.
Thank you so much. And I am, first of all, I have to apologize. I am in my car because I'm coming from a late lunch in the clinic. So I'm going to shut my video off and talk so it's less distracting. And first of all, I wanted to say good evening to everyone. Good morning. Listen to me. Good evening to everyone. And my name is Julene Vidic, and I'm a hepatology pharmacist from AbbVie. We are very honored to sponsor and be part of this webcast. AbbVie is focused on developing innovative science and technologies while working together with you, our healthcare provider partners, to make a remarkable impact in the lives of patients. As a leader in the treatment of chronic hepatitis C, we are always innovating for the future. We are committed to leveraging our deep scientific expertise to provide treatments that are accessible with an established clinical profile to reach the end goal of hepatitis C elimination. We are focused on better understanding the needs of people diagnosed with Hep C to provide solutions that can treat and ultimately cure their disease. A patient considered cured when Hep C is no longer detectable in the blood after appropriate follow-up. We strive to do this by partnering with patients and CLA from educating on the importance of screening all adults and linking patients to care to advancing elimination efforts in hepatitis C for patients. We have made it our mission to help eliminate the burden of Hep C, which I know is important to all of you. Again, we are grateful to have this opportunity to sponsor this webcast, and thank you for your time, and I hope you all have a great meeting. So again, thank you so much. I appreciate it, and I'm sorry about the distraction that I'm in the car. So thank you all. Have a great meeting.
Now, thank you so much, and thank you to AbbVie for your sponsorship.
You are most welcome.
Heather with ISI will now be presenting to us. Thank you.
Yeah, thank you. This is Heather, and I work with ASI. And I first wanted to thank the CLA for giving us an opportunity to sponsor the program. And I just wanted to take a second to introduce myself, Heather Malarchik, and mention my two partners, Faith Maloney and Ryan Connors. And between the three of us, we support Lenvima or lenvatinib for first-line treatment of patients with non-resectable hepatocellular carcinoma. And we support almost all of PA, Northern West Virginia, and Western New York. So if anybody has any questions or would like any information, we have a lot to share. So feel free to, I think our phone numbers and emails are in our chat room. Feel free to contact us anytime. We're here to help. And thanks again too for the CLA for letting us be a sponsor. So everybody have a great night and thanks again.
Thank you, Heather. We appreciate that. Again, thank you for your sponsorship. And again, we have those breakout rooms in the CVent chat room online and through the app on the phone. Next, Alicia Hardin from Gilead. Would you like to speak?
Hi, how are you? Thank you so very much for having us. We really appreciate the opportunity to be here on behalf of Gilead Sciences and the Hepatitis C division. My name is Alicia Hardin and I'm the Hep C specialist in the Pittsburgh area. And hello to everyone out there. So we understand the challenges that COVID has brought forth to each of you. And we know that you're short-staffed and a bit more stressed out probably today than you were, 2 years ago today. So, and that your hepatitis C patient population, it's seeing an increase in probably antipsychotic medications, unstable housing situations, and they may not even know where their next meal is coming from. That probably sounds familiar to a lot of the providers that are out there. So we at Gilead Sciences, we understand the challenges that you experience on a regular basis as a provider. And that is why Epclusa or sofosbuvir velpatasvir is still the #1 prescribed hepatitis C regimen in the United States. And I'd like to challenge each of you to reach out to either myself or your local hepatitis C specialist and ask them why prescribing Epclusa is the only solution for your patients. Aside from being the only hepatitis C regimen that has no contraindications when taken alone, Epclusa's authorized generic is now preferred on all Pennsylvania managed Medicaid plans. So insurance coverage is no longer an issue. And again, please reach out to myself or your local hepatitis C specialist. So thank you again to the Community Liver Alliance for having us. We're proud to be sponsors.
Thank you, Alicia. And now we have Dave Wharton from Gilead as well to speak.
Hi there, how you doing? My name is Dave Wharton. I'm with Gilead Sciences, and we're grateful for the partners for the Community Liver Alliance and support for their fine work in trying to educate, and it kind of goes with their slogan, global awareness is local impact. So I think that's a good thing. So I represent a product called Vemlidy for the treatment of hepatitis B. Vemlidy is a pro drug from the family of nucleotides. So it's a kind of an interesting story when you go back and look at our history. Our founder was a true believer in the science, was the late John Martin, and he was at about 30 years ago plus. He was at Bristol Myers, and they disagreed on exactly about nucleotides because they didn't want to go that direction. So in his parting ways, they gave him the patents when he left to nucleotides, and his vision has given us all the opportunity to be able to help patients with HIV, Hep C, hepatitis B, and coming soon there'll be a hepatitis Delta product for us for later this year, hopefully. Vemlidy is the latest of the tenofovir prodrug with efenamide. This version has the same efficacy as tenofovir, the old tenofovir, disproxil fume, which is Viriad, which you probably have heard before, and some of you guys use that product. But the nice thing about it is with Vemlidy, you're getting 90% reduction in tenofovir. You're having less effect on the bone mineral density of the patient and less stress on the renal function. So this makes Vemlidy a perfect option for your hepatitis B patients. So, at Gilead, we like to strive to meet unmet medical needs through transformational science. So I appreciate your attention. I appreciate your time. Thank you.
Thank you so much, Dave. And again,
you.
thank you to Gilead Sciences for their sponsorship. Lastly, we have Genentech with Neil Hall. There you go. All right, thank you. Welcome.
Thanks, Jill. Good evening, everybody. My name is Neil Hall. I am a therapeutic area manager for Genentech. And in my role, I'm responsible for the FDA indication for Tecentriq in combination with bevacizumab. It's indicated for the treatment of patients with unresectable or metastatic hepatocellular carcinoma who have not received a previous systemic therapy. It is also an NCCN Category 1 preferred option and the only preferred first-line systemic therapy option for those unresectable HCC and metastatic HCC patients as well. I appreciate the opportunity to speak with all of you tonight. Hopefully you'll stop in the virtual booth that we have. And once again, I would like to thank the CLA for giving us this opportunity to interact with all of you. I have other colleagues as well that have the same role as mine. So if you do reach out in the virtual booth, I'll be able to contact the appropriate people for your area. So thank you very much.
Great, thank you. Thank you again to AbbVie, ISAE, Gilead Sciences, and Genentech for your sponsorship, as well as Allegheny Health Network for their support in this program tonight. One last time, I'd like to remind you all to collect your CME for tonight. You have until 6 a.m. tomorrow morning to log on to your email and respond to the email that I send. It will have a phone number that you have to send a text message to. It has a link that you have to click onto. You fill out an evaluation and automatically your CME will be sent to you in a downloadable format that you can print or save to your computer. So thank you so much for your attention during this break. Still feel free to visit the virtual booths from our sponsors via Cvent on the phone app or on the website. And now we'll continue with the program and Dr. Babbage can introduce our next speaker. Thank you so much for your attention.
Thank you again, Jill, and welcome back, everyone. We're going to continue with our next talk. I'd like to introduce our next speaker is Dr. Maruf Hotait. Dr. Hotait is an associate professor of clinical medicine at the University of Pennsylvania. He co-founded and directed the multidisciplinary liver tumor clinic at Penn since 2009. He also serves as the medical director of liver transplant and the transplant hepatology fellowship director at Penn. His clinical and research interest is in liver transplantation for malignant disease, and he'll be speaking to us about an update regarding hepatocellular carcinoma. Dr. Hotait.
Thank you, Dr. Babbage, for the kind introduction and invitation to speak. Thanks also to Dr. Kroc. As Dr. Kroc is, I'm also a Philadelphian, as you can tell from my accent, though naturalized in this case, not born and raised. Today I'll talk about hepatocellular carcinoma updates. I chose for this talk not to focus exclusively on updates from the liver meeting. To make it more broad, it's more, the idea is that I wanted to provide an update in HCC 2022, so to speak, focusing on updates in the past year. Go to the next slide. These are my disclosures. Next slide. So I will focus on 4 areas in terms of updates on HCC. One related to surveillance, second, related to liver transplant for HCC, third, liver-directed therapy for HCC, and finally, systemic therapy. And as I said, the studies that I'll mention, some were presented in the liver meeting, others were presented in other national meetings, and I will also touch on a few key publications in the past year. Next slide. Starting with HCC surveillance, this is what we know based on the AASLD guidelines. Patients with cirrhosis should undergo surveillance for HCC every 6 months. The modality of choice as recommended by the AASLD is ultrasound plus or minus alpha-fetoprotein. And AASLD mentions that you can use CT or MR in select cases if you have a poor quality ultrasound. The guidelines also mention that there are novel biomarkers that are promising, but advanced phase studies are needed for confirmation. And the asterisk here is that we know that ultrasound and AFP is far from being the optimal modality for HCC screening. It is just the one for which we have the best evidence. The reality is ultrasound plus or minus AFP can miss up to 1/3 of curable HCC. And this is an area of active research, and I'll focus the next discussion on this aspect. Next slide. So one main area of research in improving HCC surveillance is developing better biomarkers. We know AFP alone as a biomarker for HCC is less than ideal, specifically because it gets elevated in the advanced stage more often than it does in the early stage. In other words, you're more likely, if you use AFP alone as your screening test, to pick advanced stage HCC. There's also a subgroup of HCCs, between 20 and 30% of tumors don't produce AFP even when they are advanced. So AFP is less than an optimal marker, and ultrasound, as we discussed, has the caveat of potentially missing curable disease. So there is a lot of research in identifying better biomarkers. And this is an example of a study that was run at our center as well as others in testing an HCC panel that uses cell-free DNA as a tumor marker. And there's a methylation pattern at 3 loci that are identified. And when combined with AFP and AFP-L3, which are more traditional markers, adds to the performance characteristics of biomarkers for HCC. So here is the performance of this novel HCC panel in detecting early stage curable HCC. And you can see that it performs better than AFP, AFP-L3, and DCP, which are the currently commercially available markers, and better than a scoring system called GALAD that basically combines the 3 markers, DCP, AFP, and AFP-L3, as well as parameters related to age and sex. The panel sensitivity was 71%, specificity 90%, which is significantly better than what you expect from AFP alone, which is the otherwise most commonly used marker, which tends to have a sensitivity in the 45 to 50% range. This was a case control study, though, and this is needs to be confirmed in a phase 3 study of screening patients at risk rather than just comparing cases and controls. And this is an ongoing study right now. Next slide. The other advance in HCC surveillance is using novel imaging approaches. As we discussed, ultrasound can miss a substantial proportion of curable tumors. It has been known for a while that if you use cross-sectional imaging, the traditional contrast-enhanced CT or contrast-enhanced MRI, there are also difficulties for using these modalities in screening. CT there's concern about cost effectiveness, but also of radiation exposure due to repeated CT exposure. And MRI is far too expensive to be effectively used for screening of patients at risk. In this study, which is a meta-analysis of different trials of utilizing a variation on MR as a screening modality. And here, instead of using your traditional contrast-enhanced MRI, the idea is that you could use an abbreviated version of MRI, either non-contrast study or using a single-phase hepatobiliary imaging, as in using EOVIS enhanced MRI, which means that you would inject contrast and image once 30 minutes later. The idea is that time under MRI is really what is the barrier to utilization of this modality effectively, and that if you have an abbreviated version of MR, then it'll be less costly and potentially more cost-effective for HCC screening. So this is a meta-analysis of such studies of abbreviated MR of different types. This is it included 15 studies of about 2,800 screened patients, and the per patient sensitivity was 86%, per lesion sensitivity is 77%, which is a marked improvement over ultrasound. It clearly is more sensitive for detecting tumors that are more than 2 centimeters, less so for less than 2 centimeters, but in either case, substantially better than ultrasound. And this diagram here might be a little bit too small to see it clearly, but you can see that the different bubbles here refer to different subtypes of this abbreviated MRI that are used in different studies, either with contrast, with diffusion weighted imaging, which is another non-contrast MRI technique to detect focal lesions. And regardless of the specific technique, you see they cluster around, having an 80% or so sensitivity, which is better than what you see with ultrasound, which is closer to the 50% range. So in terms of surveillance, the advances are focused on better biomarkers and potentially better or more cost-effective imaging techniques. Where we'll end up in terms of the next few years, we'll probably have better biomarkers, and I would say probably also develop a better MR-based screening technology. So potentially we're looking at advances in screening in the next few years that will improve our ability for early detection. Next slide. And here's the bigger problem with screening. This study aimed at looking at the screening and surveillance in patients with cirrhosis in general, including screening for varices and screening for HCC. And in this, I focused on the part of that study that looked at HCC surveillance utilization in HCC. It's a database study of private insurer claims. About 80,000 patients included with cirrhosis between 2007 and 2016. And what this shows is a fairly shocking number, that about 50% of patients with cirrhosis do not undergo any type of screening in the 2 years that they are followed. And screening here is defined very loosely, as in any ultrasound, any CT, or any MRI in that time frame. And you could see that we could do better in terms of screening patients. And when you look a little closely at the subgroup analysis, what is evident is that patients who have cirrhosis who are followed by a specialist, and in this case, specialist was defined broadly as either a gastroenterologist or an ID physician, as some patients have viral hepatitis and are seen followed by an infectious disease specialist. But if you're seen by a specialist, then the utilization of screening is significantly higher than patients followed by a primary care physician only. Again, emphasizing the importance of specialty consultation for patients with cirrhosis. The other item of interest in this study is that over time we appear to do better. There is more and more recognition as the utilization of screening improved during the time frame of the study. Yet there is a lot of work to do. There's a lot of research on improving our screening modalities, but this clearly needs to be coupled also with improved utilization of screening in patients with cirrhosis. Next slide. Next key area of update is liver transplant for HCC. What we know is, of course, that the standard criteria for liver transplantation for HCC have been established since the mid-1990s with the Milan criteria, basically showing that the outcome of liver transplant for patients with hepatocellular carcinoma with lesions, either a single lesion less than 5 centimeters or up to 3 lesions, each less than 3 centimeters, in the absence of vascular invasion of metastatic disease, that's the circumstance under which the outcome of liver transplantation for cancer is equivalent to the outcome of liver transplantation without cancer at roughly 70% 5-year survival. This is what the Milan group had demonstrated in 1996, and that remains sort of the gold standard for transplant for HCC. More recently, UNOS adopted the concept of downstaging, which is the fact that there is a subgroup of patients that respond well to neoadjuvant therapy of HCC, predominantly liver-directed therapy with TACE or ablation, at least in the original study, that's showing that if you bring the tumor down to the viable component of the tumor to become within Milan criteria after therapy, then the outcome is equivalent to transplant for tumors that are within Milan. And the downstaging criteria have very specific size limits. So if the single lesion is allowed to be up to 8 centimeters, and as the number of lesion increases, the top size for the largest lesion is decreased, and the sum of the diameters need to remain below 8 centimeters in all cases. So this is the downstaging criteria that are adopted by UNOS right now, and you are allowed to get priority points for transplant if patients with these tumor size limits are treated, and the tumor is downstage, as in the tumor's volume, the viable tumor volume is reduced to within the Milan criteria. So this has been established for the past few years. The question that, next slide. So the question that we and others have asked is whether these size limits actually matter. This is a US multi-center study in 82 patients called All Comers. This is basically saying that here we're not concerned about any size limits. We're concerned about just trying to bring the tumor within Milan criteria using neoadjuvant therapy. So 82 patients who fit these beyond downstaging criteria, but yet still don't have evidence of vascular invasion and no metastatic disease, were compared to 230 patients who met downstaging criteria. And you could see that your likelihood of successfully downstaging as tumor volume increases clearly is lower. So the overall likelihood of downstaging patients that are within the standard criteria is in the 80% range, whereas here for all comers, we found that that number is closer to 67%. But if you do get the patients to transplant, and this data is here rather preliminary because of relatively small numbers of patients that did get to transplant, their outcome post-transplant is not very different from patients who meet downstaging criteria. So in essence, this is meant to say that perhaps what matters is not so much size and number, but rather response to therapy. And it is, I think, an important concept in HCC. And I think since the days of the Milan criteria, since the Milan criteria were developed, the focus for potentially curable disease is tumor size and tumor number. But we know that this really skims at the surface of tumor biology, that we really need to look deeper as to what are the true biological markers of curable disease. And this is an area of active research. But one of the markers of curable disease is stability with time, response to neoadjuvant therapy and stability with time. And both the concept of downstaging and this new concept of all comers potentially also being curable get at that aspect. Next slide. So what about pushing the envelope here? What about vascular invasion? Is it a contraindication to liver transplant? Of course, the standard criteria for transplant for HCC all presume that there is no metastatic disease, obviously no extrahepatic disease, and no vascular invasion. Though there was a number of case reports and a small case series from an international study from a couple of years ago showing that there are patients with vascular invasion that do respond well to therapy and then are able to undergo transplant without recurrence after transplant. Though this was not tested in a systematic way. These are our individual case report. And in this study, there was an attempt at looking at this problem more systematically, as in looking at consecutive patients with vascular invasion, and are we actually able to get them to transplant successfully? And I would say the summary is that the results are rather disappointing. This is a single center pilot study, 17 patients with HCC and portal vein tumor thrombus. They only allowed patients to have involvement of a first order branch, as in you're allowed to have either a right portal vein invasion or a left portal vein invasion, but not a main trunk invasion and not an invasion on both sides, right and left. So that's kind of how they selected their patients. They treated all patients with radioembolization and offered liver transplant if they have a sustained response for 6 months. Of the 17 patients enrolled, they were only able to downstage 6 patients. Of the 6, 1 subsequently progressed, and so was not transplanted. 5 were transplanted, and of the 5 that were transplanted, 3 recurred at 1 year. So clearly, liver transplant for disease, for tumor with vascular invasion is not by any means a standard of care for these patients. There's probably a select group, as was shown in prior case reports, that does benefit from transplant, although that select group is not very well defined. And here, I think we have to await better tumor markers or better molecular markers of tumor behavior, and perhaps selecting the patients better if we were to offer transplant to a select group of patients with vascular invasion. Next slide. Liver-directed therapy for HCC. And here's the guidelines from the ASLD for liver-directed therapy. The best evidence is for chemoembolization because it's the oldest liver-directed therapy modality that's been present for a long time, and it's been even compared to supportive care only, which is not something that has been done with any other study. There's the evidence for other liver-directed therapy modalities are much lower. That includes transarterial bland embolization, transarterial radioembolization, external radiotherapy that are routinely used, but the difficulty is that there isn't good quality randomized prospective studies showing their effectiveness, especially effectiveness compared to TACE. I'll go over a couple interesting studies related to radioembolization next. So next slide. So 2 studies in the past year that show that one important concept is that with radioembolization in particular, technique matters. So there's a variety of techniques to deliver radiotherapy and radioembolization, and there is this standard dosing modality, which is making sure that no liver lobe gets more than 120 gray total of radiation as a safety threshold to reduce the risk of toxicity. And there is a more personalized way of trying to target a high dose of radiation to a single target lesion. And so in this study, with larger tumors, 60 patients were treated either with the standard dosing or with high dose localized therapy. And you can see that if you deliver radiation at a high dose locally, the survival is better and the tumor response is better. So obviously there's a big difference in tumor response, 71% versus 36%. And that is reflected in the survival benefit. The downside is as you use higher doses of radiation, and even as you try to localize to the target lesion, there is a higher rate of liver injury, 6% versus none in the standard approach. But perhaps even with that caveat in mind, given the survival benefit, this should be probably the standard way how radioembolization has been done. And this is a difficulty, again, in these studies that compare these liver-directed therapy modalities, is that you have to pay attention to the specific technique that is utilized, because sometimes there's a big difference in outcome depending on the specific radiation delivery modality. Next slide. This might be a little bit hard to see, but this is a US multi-center retrospective study looking at treating single lesions with radioembolization, again using this modality of personalized sort of high dose radiation delivery to a single lesion. Selected obviously patients with child A and good performance status. The interesting thing about this is that if you look at the first survival curve, and it might be a little bit hard to see here, but this is the time to progression. The upper curve here refers to the local progression, as in the treated lesion. So with this high dose radiotherapy, you almost don't see progression locally at all. You do see progression as in the development of other lesions in the liver, particularly as the lesion size increases. But this just points to the effectiveness of this modality for treating a single isolated lesion, that you can actually control that lesion very well. Next slide.
Dr. Hotite?
Yep.
If I may, but I'm sorry, I apologize. We are getting tight on time for the presentation. If we can make our last few final points to move on to our next speaker, that'd be great.
Okay.
Thank you.
So I'll go over this part very quickly. Systemic therapy for HCC, we can skip what we know already. Just want to point out, next slide. Just want to point out that there are new drugs coming to the forefront in HCC therapy. This is an example of two drugs that are being tested in first line that are both immune activating agent, PD-L1 inhibitor and CTLA-4 inhibitor. Again, promising. This is a drug that will likely it's been presented to the FDA and will likely get approval for a new first line treatment for HCC. Next slide. And that's basically it. Thank you.
Thank you so much. You know, we are in a epidemic of HCC, I feel like, and as hepatologists, there are so many more tools than when this all started with just TACE, years ago now, looking at so many different things. So thank you very much for that excellent overview, Dr. Hotite. Nice to see you again as well.
Great to see you. Take care.
Excellent. Well, I'm pleased to introduce our next speaker, Dr. Allison Faust, who will be speaking on updates on PSC and PBC. Dr. Faust studied at Jefferson Medical College, then progressed on to Duke University for her internship and residency in internal medicine, where she also did research and completed a GI and hepatology fellowship there as well. Her current research interests do include quality improvement and patient-reported outcomes. And she has extensive experience as a lecturer in gastroenterology and hepatology topics for medical students, residents, and fellows, and has served as a facilitator for Hepatology Journal Club for fellows. She's lectured on liver disease at several state and national conferences, including the ACG regional meetings, ALF, PSC conference, and the Pennsylvania Society of Gastroenterology Nurses and Associates conference. So excellent, Dr. Faust. Nice to see you. And she's one of my colleagues at Penn State Milne Hershey Medical Center now.
Yes, I am very fortunate to work with Dr. Crack and very excited to be here with you all tonight amongst this great panelist of speakers from all over the state and even in Texas. My talk today is going to be on updates in primary biliary cholangitis and primary sclerosing cholangitis with a really heavy focus on information that was presented at the here. Next slide, please. So basically through the talk, what I'll do is go through just a couple background slides for primary biliary cholangitis and primary sclerosing cholangitis, just for context purposes. And then I'll cover some of the oral presentations, posters of interest that caught my eye and that I thought were clinically applicable to your practices. Could you go back, please? Sorry, I will also spend a little bit of time reviewing the PBC autoimmune hepatitis overlap syndrome. There was a really nice autoimmune cholestatic SIG talk on this that I thought had some really nice clinical pearls. And then lastly, I'll go over the management of pruritus, which has changed a little bit in the guidelines from when I was in training. Next slide, please. Starting with primary biliary cholangitis, as we know, this is an autoimmune disorder characterized by granulomatous destruction of the small bile ducts. This results in chronic cholestasis and can lead to cirrhosis in up to a third of patients. For kind of board exam purposes, classically, this is a middle-aged female that's coming to you with fatigue and pruritus. This is a diagnosis that we're making through both blood work and histology. This is not something we're seeing on imaging. So to make a diagnosis, we need two of the following three criteria: an elevated alkaline phosphatase, a positive antimitochondrial antibody, and or biopsy findings consistent with PBC. That means that you can make the diagnosis without a biopsy in patients that meet those first two criteria, and you may need a biopsy if you're concerned about AMA negative PBC, which can occur in about 5% of patients. And clinically, you also may see an elevation of serum IgM. Next slide, please. These are just your histology buzzwords that you might see on a pathology report that will trigger your mind towards thinking that the patient has primary biliary cholangitis. The inflammation is going to be predominantly based in the portal tracts. You may see a florid duct lesion, which is a significant amount of inflammation surrounding the bile ducts. You may see granulomatous inflammation in the portal tracts, bile ductular proliferation. And the last thing on this list I think is particularly important to keep in mind. You can see some degree of interface hepatitis with PBC. We classically think about interface hepatitis with autoimmune hepatitis, but you can see this in PBC in quite a few patients, as I'll demonstrate in a couple of slides. Next slide, please. So once we've made the diagnosis, we're looking at treatment. And the cornerstone of treatment has always been ursodeoxycholic acid or ursodiol. We're using that at a dose of 13 to 15 milligrams per kilograms per day in divided doses. We generally will start it and then we'll assess for the response to that. Response is defined as an alkaline phosphatase less than 1.67 times the upper limit of normal 6 to 12 months after starting therapy. We know ursodiol has a long track record of use. We know it can improve rates of death and slow progression and reduce the rates of liver transplantation for PBC. However, up to about 40% of patients won't respond completely to ursodiol, and another percentage of people will be intolerant to ursodiol. And those are the patients that we're targeting for second, third line therapies and even clinical trials. So several years ago, we began using obeticholic acid for patients that were not responding completely to ursodiol or were intolerant to ursodiol, typically starting that at 5 milligrams and increasing to 10 if it's well tolerated. We do see a significant amount of itching with that medication. Sometimes that limits the patient's compliance with the medication. And we can also see some effects in the lipid profile, and that needs to be monitored as well. We've learned over the last couple of years that these medicines are not to be used in patients with decompensated cirrhosis or compensated cirrhosis with varices. So another option for ursodiol non-response could be to use a fibrate. Now, this is not FDA approved for PBC, but seeing more and more research studies using a fibrate, typically in conjunction with ursodiol, to get better biochemical responses. There hasn't been studied long enough to really know whether we're seeing improvements of mortality and transplantation, but we are seeing some data suggesting that there's significant improvement in itching with fibrates. And of course, we've got some ongoing clinical trials, some of which were presented at the liver meeting today that I'll summarize. Next slide, please. So this is just a summary slide looking at some of the mechanisms that the new therapies for cholestasis are targeting. These are encompassing both PBC and PSC in this particular slide, but looking at bile acid modulation, fibrosis pathways, inflammatory pathways, and then I'm not really talking today much about immunomodulation, but those are also some things that are in study. Next slide. Specifically for PBC, what we're seeing most in study are agents that are targeting the PPAR pathway and the FXR pathway. So if you're really interested in biochemistry, you can study this slide here looking at the bile acid pathway, but you'll see some familiar names on this list. A lot of these are agents that are also being studied in fatty liver. So they probably look quite familiar. Now your fibrates are PPAR agonists, and your obeticholic acid is an FXR agonist, just for point of reference. So keep these names in mind as I go through some of the liver meeting presentations from this year. Next slide. So taking a little bit of a step back in terms of not talking specifically about therapy yet, but and there was an oral presentation where a group took a proteomic approach to look for biomarkers that could help identify those that will respond to ursodiol or won't respond to ursodiol. So they took healthy controls and PBC patients that had been treated with 1 year of ursodiol, pulled the samples and used liquid chromatography, mass spectrometry to look at markers that separated the urso responders from the non-responders. And they found 3 promising biomarkers with that technique. So obviously it's a very preliminary study, but it would be really interesting to be able to have a biomarker that would help you determine that ursodiol non-responder earlier so that you could get them on additional therapy. Next slide. Second oral presentation that caught my eye was a study, the long-term 2-year results from the long-term study of seladelpar in PBC. So this is a PPAR agonist. This study looked at 103 patients, again with inadequate response or intolerance to ursodiol. These were patients that were enrolled in an open label 1-year phase 2 study, but then after that they went into a longer term study, and these are the 2-year results from the longer term study. The endpoint was % change in alkaline phosphatase. The study was terminated early due to an abnormal biopsy finding in a concurrent NASH trial that was not related to the drug. But for this analysis, 97 patients were included. There was significant alkaline phosphatase change, -42% and -50% at 1 and 2 years with the drug. And alkaline phosphatase normalized in about a quarter and 42% of patients at 1 and 2 years. Pretty well tolerated medication. Only a couple patients, 3 patients had to stop for adverse events that were most commonly itching, nausea, and fatigue. Next slide. Couple of posters that were interesting to me. The seladelpar was looked at in patients with compensated cirrhosis and portal hypertension. Remember, we can't use obeticholic acid in these patients. So this was a study looking whether we had the same problems with seladelpar, and ultimately looked to be safe and well tolerated. And actually the efficacy looked comparable between patients with and without cirrhosis. There was another poster that looked at bezafibrate as a second-line therapy used in combination with ursodiol, and 12 of 15 patients achieved a significant alkaline phosphatase improvement. And so this was concluded to be an effective second-line therapy in patients with inadequate ursodiol response. Next slide, please. So moving on a little bit from PBC alone and into the overlap syndromes, Lily Dara gave a really interesting SIG talk about this, and there was a couple of points that I took home that I wanted to share that I thought were very clinically applicable. So this first slide is basically showing how much autoimmune hepatitis and primary biliary cholangitis can share features. And it's important to really take caution in diagnosing the overlap syndrome, because all of the findings really may be consistent with the primary disease. So for example, patients that have autoimmune hepatitis can have an alkaline phosphatase over 2 times upper limit of normal in about 20% of the patients. They can even have biopsy findings that seem more like PBC, but are still fitting in with the autoimmune hepatitis primary diagnosis that could include non-suppurative cholangitis, even florid duct lesions and ductopenia. And up to a third of patients will have a low-level positive AMA. And this is something I see pretty often in clinical practice. Patients with autoimmune hepatitis in this low-level AMA kind of get diagnosed as an overlap, and maybe it's not truly an overlap and all just consistent with single autoimmune hepatitis. If the patient has primary biliary cholangitis, there can be some features that are suggestive of autoimmune hepatitis as well. Up to half of patients will have moderate interface hepatitis, and 25% will have severe. There may even be plasma cells or autoantibodies seen as well. So next slide. So this is the Paris criteria that I think is important to just reference when making the diagnosis for the overlap syndrome. You need 2 of 3 criteria for each autoimmune hepatitis and PBC. And for autoimmune hepatitis, you need the moderate to severe interface hepatitis, an ALT greater than 5-fold upper limit of normal, immunoglobulin greater than 2-fold upper limit of normal, or presence of anti-smooth muscle antibodies. So 2 of those 3 gives you the autoimmune hepatitis check mark. For primary biliary cholangitis, if your alkaline phosphatase is greater than 2-fold upper limit of normal, or GGT over 5-fold upper limit of normal, an AMA titer greater than 1/40, and pathology findings of florid duct lesions or destructive non-suppurative cholangitis on histology. So I think, this is an important slide that I'll keep with me clinically just when I'm going to diagnose overlap syndrome for these conditions. Next slide. There was an interesting oral presentation looking at autoimmune overlap when it came to liver transplantation that was presented at an oral session. So this looked at graft and patient survival following transplant in patients that had autoimmune overlap syndrome. We looked at 172 patients, and they wanted to identify predictors of recurrence. They saw recurrence in about 20% of patients. The predictors of recurrence were increased alkaline phosphatase at 6 months after transplant. And then some, I think, rather non-specific things like having a positive actin antibody or a high IgM, and then use of tacrolimus and cyclosporin, which I presume was probably most of the population. But what was really interesting about this to me was that the 5 and 10-year graft survival was significantly lower in the group that had recurrence of autoimmune overlap. So 5-year survival, 68%, 10-year survival, 41% in the recurrence group, compared to 92 and 79% in the non-recurrence group. So really highlighting the importance of identifying this early and making sure you're maximizing treatment. Next slide. Moving on to primary sclerosing cholangitis. As we know, this is a fibrosclerotic disease of the biliary system where you get stricturing of the bile ducts and subsequent dilation that can predispose you to getting infections and cholangitis. The disease can be progressive, resulting in biliary obstruction, cirrhosis, liver failure, and need for transplantation. Can progress fairly rapidly. Next slide. As opposed to PBC, we're usually making this diagnosis based on imaging, typically an MRCP, but if an ERCP is done, this is a classic image from that with the beads on a string appearance. And if a biopsy is done, you may see onion skinning as the classic finding, but it's not commonly seen, and it's also not completely specific for PSC. Next slide. Unfortunately, we don't have an effective drug therapy for PSC. Sometimes people will use ursodiol. The data is mixed about doing so. And we know that in high doses, at a dose of 28 to 30 milligrams per kilograms per day, we were actually seeing harm with ursodiol use. Using a PBC dosing with the 13 to 15 milligrams per kilogram may improve alkaline phosphatase in some patients, and that may ultimately lead to improvements in their clinical situation. But again, this isn't recommended in the guidelines and has a lot of mixed data about the use. We're typically using ERCP really solely when we're seeing a dominant stricture, making sure it's not a cholangiocarcinoma, and performing therapy if we're needing to dilate or leave a stent in place for biliary drainage. No longer really using ERCP much from the purposes of just plain PSC diagnosis. And of course, we're having to watch very carefully for the development of cancer in these patients. Cholangiocarcinoma can occur in up to 15% of patients. A lot of the times is present at the diagnosis of PSC, but can develop over time. We're also seeing elevated risks of hepatocellular carcinoma, especially if cirrhosis is present, gallbladder cancers, and colon cancer. So the data is mixed in terms of surveillance, but most people would advocate for some form of abdominal imaging with or without a CA19-9 every 6 to 12 months. So very non-specific. I tend to favor the 6-month strategy, doing an ultrasound and mixed with an MRCP, kind of alternating from there. And of course, at the diagnosis of PSC, if the patient does not carry an IBD diagnosis, they do need a colonoscopy with biopsies to look for the presence of IBD. And if they have IBD, they need a colonoscopy every 1 to 2 years ongoing. If they're post-transplant, that needs to be every 1 year. Next slide. So a couple of oral presentations for PSC. One was they presented some data using berberine ursodeoxycholate in patients with PSC. So this was a little bit of an extension of a prior study where they had looked at this agent, but the study was confounded by some patients that had been previously exposed to ursodiol. So this particular analysis excluded anyone that had been exposed to ursodiol before. There was 30 patients, one serious event that wasn't related to the medication. And there was pretty nice biochemical response with this agent, particularly at the 1,000 milligram twice a day dosing. Next slide. So cilofexor is an FXR agonist. We see that studied in fatty liver sometimes. This was a 96-week open label extension of a phase 2 study. This included 47 non-cirrhotic PSC patients that continued on into the open label study. Pretty significant number of them had to stop treatment early for itching or other adverse events, I think, which is notable. That's almost a third of the patients. And there was a pretty significant biochemical improvement that was seen pretty soon after the initiation of the drug and extended through week 96. But as soon as the drug was stopped, there was a rebound effect with increasing alkaline phosphatase again. Next slide. 2 posters of interest. The first was that there was a group that looked at the number of cholangitis episodes to see if this would predict mortality in PSC. They looked at patients waiting for transplant, did a landmark analysis of survival. They found that patients that had more than 3 episodes of cholangitis had a higher waitlist mortality with a hazard ratio of 2.93, and proposed that we consider eventually awarding extra MELD points to these individuals. There was a study from Duke that looked at the complementary and alternative medicine use in patients with PSC. They looked at 95 patients, surveyed them about their complementary alternative medicine use. A third of patients had reported use in the past 12 months, 60% specifically because of the PSC. Almost 50% reported use of potentially hepatotoxic herbs, and less than half told their hepatologist they were doing this. And the most common reasons were to improve their general wellness and improve energy. And I think this just speaks to the importance of evaluating our patients' symptoms, making sure we're addressing them, and really trying to get to the bottom of what they're taking and making sure they're not taking things that could further injure their liver. Next slide. So speaking of managing symptoms, I thought there was a really nice clinical practice SIG talk on the management of pruritus. Interestingly, and a little bit to my dismay, I found that antihistamines are no longer really recommended. Apparently, they've not been shown to have any significant benefit. But anecdotally, I still have patients that kind of swear by them. So I don't know if I'm quite ready to let them go yet, especially for that nighttime itching because of the sedating effect in my non-cirrhotic patients. But really, the algorithm for using agents for itching in all patients, focusing on supportive care. So talking with them about using emollients, oatmeal extract, moisturizing agents, an agent that has 1 to 2% menthol can be particularly soothing, making sure fingernails are short so they're not getting significant excoriations, and applying cold water after warm situations. It's worth spending that minute or two going through those things with the patients. And then in a stepwise fashion, looking at cholestyramine first, rifampin, naltrexone, sertraline, and then moving on to third and fourth line therapies of fibrates, MARS, phototherapy, plasmapheresis, and liver transplantation. But I think it's important to note that now that we have the National Liver Review Board, there's no longer an easy mechanism of getting exception points for transplant for itching. And so live donor transplant may be the way to go. I have one more slide. Go ahead and move to that. This is just a summary slide of the pruritus agents. Cholestyramine can be poorly tolerated due to abdominal symptoms. Rifampin can have a good effect, but has some risk of hepatotoxicity. So be careful in cirrhosis. Also look for drug-to-drug interactions. Naltrexone we can't use in patients on narcotics or with chronic pain on narcotics. And then sertraline has to be used at a fairly high dose, but has the benefit of also treating any concurrent depression, but certainly worried about risks of serotonin syndrome if there's other serotonin agents on board. Next slide. So just a couple key takeaways. A lot of the new PBC and PSC therapies are targeting the FXR and PPAR pathways. PBC and autoimmune hepatitis share some common features, so look at that Perry's criteria to make the diagnosis of overlap. And antihistamines are no longer first-line itching agents, address supportive care, and utilize pharmacologic agents in a stepwise fashion is recommended. Next slide is just my thank you. I appreciate your time. Hope you have a great evening.
Dr. Faust, thank you for a really fantastic presentation, and both in regards to both a terrific review and summary and an update on some new data. There's a lot of exciting stuff, I think, on the horizon, hopefully, for management of PBC as new line agents. PSC tends to be the great unmet need.
Mm-hmm.
Do you have any experience using vancomycin? I know that comes largely from the pediatric population.
Yeah, you know what, I see it, especially in social media sites and things like that, anecdotally, people finding success with it. I haven't personally used it, but I look forward to seeing more data come out about its role in PSC.
Thank you. Well, it's now my pleasure and actually a great treat and honor to introduce our next speaker, Dr. Nabia Mohiuddin. Dr. Mohiuddin is one of our current GI fellows at Allegheny General Hospital in Pittsburgh. And you may remember her from the presentation she gave us last year at this meeting. In spite of that, she decided to come back and bless us again with her presence. She's going to teach us today, give us an update on viral hepatitis B and D, because we're all tired of hearing about C. So Dr. Mohiuddin is a Fulbright scholar, and she's the recipient of the ACG Presidential Award for research she did on palliative care in hepatology. We were actually so excited to learn earlier this year that she was accepted at UPMC as a liver transplant hepatology fellow for next year, and we'll miss her very much. After her graduation, she intends to work as a transplant hepatologist with a special interest in the role of palliative medicine for patients with chronic liver disease. Dr. Mohiuddin, thank you.
Thank you, Dr. Babich, for your kind words. Over the next 15 minutes or so, we'll be speaking about hepatitis B and D. Next slide, please. So to diagnose hepatitis B, you need presence of Hep B surface antigen. The difference between acute and chronic: for chronic Hep B, for a diagnosis, you need the surface antigen to be present for greater than 6 months. The transmission of hepatitis B is through perinatal, percutaneous, sexual, and person-to-person contact, which is either through open sores or cuts, etc. Next slide. Who should we screen? We should screen patients who have been born in regions with high endemic rates of Hep B. In North America, these are patients who are Alaskan natives and indigenous populations of North Canada. Also, patients who've been born in the US but were not vaccinated at birth, plus parents born in high endemic regions. Next slide. This is a map from the CDC, which notes high endemic regions throughout the world. You'll see Middle East, Asia, Africa, South America, and high endemic is characterized as presence of greater than 8% of Hep B in those areas. Next slide. This is a list of high-risk patients for Hep B, IV drug users, men who have sex with men, patients on immunosuppressive therapy, elevated LFTs, end-stage renal disease, when mom has Hep B, pregnant women, chronic liver disease, HIV, household and sexual contacts, occupational exposures, travelers, inmates, and patients with diabetes. Next slide. This is a pie chart from the CDC for patients in the US. The vast majority of patients diagnosed in the US, unfortunately, we don't know how Hep B was transmitted to them. For the rest, you'll see IV drug users and sexual contacts are a big chunk of how Hep B is transmitted. Next slide. For serology, Hep B surface antigen and Hep B surface antibody, we always want to check those. We can check a Hep B core antibody. If Hep B core antibody is positive, that means that the patient has had exposure to Hep B, unless it is a false positive, which is rare with newer testing. It's positive because we checked in the window period of acute hepatitis B, or it's positive because of a Hep B surface antigen mutation. If patients are anti-Hep B surface antibody negative, they need vaccinated. And if their core antibody is positive, but they have a negative surface antigen, they cannot transmit the disease. Just to go over this, Hep B core antibody positive just means that they've been exposed. If surface antibody is negative, they need vaccinated. Next slide. What about moms and Hep B? It's safe for pregnant women to be vaccinated. It is safe for them to breastfeed if they're on treatment. Indications for treatment are standard, which we will go over a little later, as well as an HBV DNA of greater than 200,000. If patients with Hep B, moms also have cirrhosis, they should be managed by a multidisciplinary team. TDF, tenofovir, is the drug of choice. What about baby? Baby should get Hep B immunoglobulin plus Hep B vaccine within 12 hours after delivery. Next slide. When we have Hep B surface antigen present, if it's not present, we should look at the Hep B surface antibody. If that is present, that means that the patient is either recovered or is vaccinated. If Hep B surface antigen is present and IgM core antibody is present, that means that's acute hepatitis. If IgM core antibody is not present, that's chronic. The next thing we look at is Hep B E antigen or HBV DNA, which determine whether the patient is in a replicative phase or not. Next slide. To understand the treatment of Hep B, it's important to understand the phases of Hep B. Immune tolerant phase, we have Hep B E antigen positive, DNA is greater than 200,000, and we have no changes on liver biopsy. In an immune active phase, your Hep B DNA level is typically greater than 20,000, and you now have changes on the liver biopsy. In an inactive phase, as the name would imply, your E antigen is negative, your DNA is low, you have no liver biopsy changes. Next slide. So in immune tolerant and immune active, the biggest differentiation is that in active, you have inflammation or fibrosis on liver biopsy. Next slide. So Hep B is a dynamic disease. There are multiple phases of it. You don't typically have to go in a sequential pattern. For instance, in some cases, you can have Hep B surface antigen seroconversion prior to Hep B E antigen seroconversion. So if we start from the left-hand side, Hep B E antigen positive chronic infection or immune tolerant phase, your HBV DNA is high, your ALT is normal, and you have no changes on the liver biopsy. The next phase, immune clearance phase or Hep B E antigen chronic hepatitis, like we just spoke about, you now have changes on the liver biopsy. Your ALT is up and your DNA has come down. Towards the end of this phase, your Hep B E antigen will undergo seroconversion to Hep B E antibody, and then you're called an inactive carrier phase, with the ultimate endpoint being that you have seroconversion of Hep B surface antigen. Next slide. Who should be treated? The two major categories that we need to remember are the ALT level and HBV DNA. And then there are gray zones in which we look at severity of liver disease. Next slide. Treatment options. Back in the 90s, interferon was the major treatment option. And now we have tenofovir, entecavir, and most recently TAF. So tenofovir can be TDF or TAF, which is the newer one. Next slide. First-line therapy, entecavir or tenofovir. Next slide. What about patients with cirrhosis? They need treated regardless of viral load. If they're compensated, we give them entecavir or tenofovir. If they're decompensated as per guidelines, they should get entecavir. The dose should be adjusted based on creatinine clearance. Next slide. When do you stop treatment? The ultimate goal should be loss of Hep B surface antigen with or without seroconversion to Hep B surface antibody, but this is rarely feasible. Next slide. When do you not stop treatment? Cirrhotics, and as long as HBV DNA is detectable, we should not stop treatment for these patients. DNA thresholds for treatment. If Hep B E antigen is positive, the HBV DNA threshold is greater than 20,000. If E antigen is negative, the threshold is greater than 2,000. Next slide. So this is an algorithm. We'll go over this. If Hep B E antigen is positive, if you look at the left-hand side of the screen and your liver numbers are normal, even if your DNA meets the threshold, you do not treat these patients. Now coming to the right-hand side, your ALT is appropriately meeting treatment guidelines. It's greater than 2 times the upper limit of normal, and your HBV DNA is also greater than 20,000. These patients need treated. Now, what about if their DNA is between 2,000 to 20,000? This is when they fall in the gray zone, in which we need to remember 3 categories. If they have fibrosis greater than F2, if their inflammation is greater than A3, and age is greater than 40, then we treat them. And this gray zone remains the same for every category where their DNA is not meeting the threshold. So in the middle, their ALT is up, but not greater than 2 times the upper limit of normal. DNA is up, but they're still in the gray zone. So the same 3 criteria apply. Fibrosis greater than F2, inflammation greater than A3, and age greater than 40. Next slide. What about E antigen negative? Same rule. If LFTs are normal, even if they meet DNA threshold, it's greater than 2,000, you don't treat them. What about LFTs are up and DNA is greater than 2,000, you're treating them. If they're in the gray zone, either DNA is not meeting the criteria or LFTs are not, you look at the 3 factors: fibrosis, inflammation, and age. You monitor these patients closely, of course, for the first 3 to 6 months. Every 3 to 6 months, you want to get serologies, LFTs, and if they fall into greater than F2, greater than A3 or age, you should treat them. Next slide. DNA thresholds for treatment, just to go over this because it's important. E antigen positive, greater than 20,000. E antigen negative, greater than 2,000. What about hepatitis D? We check this in Hep B surface antigen positive and high-risk patients for Hep D. What defines high-risk patients is pretty similar to Hep B: patients who have ever injected drugs, men who have sex with men, individuals infected with HCV or HIV, patients with multiple sexual partners, and then high endemic areas such as Africa, Asia, Middle East. Next slide. How do we screen for Hep D? We check an HDV antibody. If it's positive, we check an HDV RNA. Next slide. The only approved current treatment is interferon alpha. The treatment goal is undetectable HDV RNA. If the HBV DNA is concurrently elevated, we can do concurrent therapy with entecavir, TDF, or TAF. Next slide. Specific research updates from the liver meeting this year. Next slide. This was a study that looked at cost-effective analysis, and what they had postulated was if we treat all the patients in the US who are Hep B surface antigen positive, regardless of whether they meet other treatment criteria or not, what would cost effectiveness look like? Next slide. So the global targets for Hep B are that we should be able to diagnose 90% of the infected population, treat 80% of the diagnosed, and reduce mortality by 60% by 2030, by 65% by 2030. They used the Markov model, which is also used in immigration studies, and they hypothesized that if current treatment guidelines are followed, above targets may not be met. Next slide. This was interesting to me. The average annual cost treatment per patient per year is $5,400 for Hep B. If we want to employ a highly cost-effective strategy, we need to lower the annual price to $750. If the continued price of $5,400 is used, the target will be met in 2037. Next slide. This is a graph that compares the different costs and when we meet treatment treatment thresholds. So the green line is we're treating everybody who has Hep B surface antigen positive. It meets the green dotted line at around 2037. This is at the rate of $5,400. And then the purple line is if we lowered the cost to $750, we would meet thresholds faster. Next slide. This study looked at the impact of COVID on Hep B and C elimination. This used data from 31 centers worldwide. Next slide. This was a web-based survey sent to all these centers, and their study showed that the total number of tests performed had decreased in most countries. And what was really interesting and stood out was that there was a decrease of greater than 50% of new Hep B treatments in 44% of centers. So it really did take a hit. This was a study that looked and compared entecavir versus tenofovir on the risk of HCC in a US cohort with chronic Hep B. Next slide. This was a retrospective cohort study. They looked at data from the VA, and their results showed that there was a decreased risk of HCC in patients treated with TDF as compared to entecavir. Next slide. This is hazards ratio from the study. They're comparing TDF with entecavir. The hazards ratio you can see is 0.89, clinically significant, does not cross the 1 line. Next slide. This study looked at the risk of stopping treatment for hepatitis B for patients in the US. Next slide. This was a nationwide cohort study. It was done in Taiwan, not the US. Patients received entecavir or tenofovir for at least a year and then stopped due to either insurance or health policy reasons. The outcome of the study was severe hepatitis flare, which is ALT greater than 5 times the upper limit of normal, or T-bili greater than 2, and mortality within 6 months of flare. Next slide. So for patients who stopped treatment after a year at the 4-year mark, the graph on the left shows a hepatitis flare in 6.58% of these patients. And the graph on the right shows mortality of 0.63% at the 4-year mark after stopping treatment for Hep B. Next slide. Severe hepatitis is not uncommon after discontinuation of treatment for chronic Hep B. There's a higher risk for older age, men, cirrhotics, and patients with hypertension. Next slide. What about the burden of hepatitis D in the US? This looked at hospitalizations for 8 years, 2010 to 2018. Next slide. They used data from National Inpatient Sample Database. There were 3,825 hospitalizations. The prevalence among patients who already were hospitalized with Hep B was 0.6%. There were more manifestations of portal hypertension, liver failure, thrombocytopenia in patients with chronic Hep B and concurrent Hep D as well. Next slide. So to summarize, we need to screen our patients appropriately. They should fill treatment criteria, which is based off of Hep B, E antigen HBV DNA thresholds, ALT levels, and severity of liver disease. The cost per year per patient for treatment of Hep B is $5,400, and there's a decreased risk of HCC in patients treated with TDF as compared to entecavir. Next slide. Thank you for listening. I'm happy to take any questions or comments.
Thank you very much for that great overview and the review of everything. You know, it's exciting to be talking about another virus other than hepatitis C, I think. I mean, no offense. I mean, thank you to Gilead and AbbVie and everyone for all the hepatitis C meds, but we can be talking about other viral hepatitis as well, too. I really do appreciate you going over that excellent overview. In the interest of time, though, I think we're going to move on to the next speaker, but thank you so much for that great interview and best of luck in your transplant hepatology fellowship.
Thank you.
Excellent. I'd like to introduce our last, but certainly not least speaker, Dr. Ramon Batelier, who is going to be speaking on alcoholic liver disease, new innovations. So thank you very much for joining us. He specializes in hepatology and practices at the University of Pittsburgh in the Department of Internal Medicine and Gastroenterology. His clinical interests do include the management of patients with alcoholic and non-alcohol fatty liver disease and critically ill cirrhotic patients. He has worked the last 10 years in a multidisciplinary team to treat patients with alcohol-induced liver disease. His main research interests do include liver fibrosis and the mechanisms and determinants of mortality of alcohol-induced liver disease. As you can see, he is appropriate to be giving us this talk. So thank you very much and welcome.
Well, thank you, Karen. Thank you, Susanna. And also thank you for the Community Liver Alliance for all the massive tasks that you do for our liver patients. Well, I will try to talk 25, 30 minutes about the alcoholic liver disease and some innovations, what is promising in a disease that have had minor advances compared to viral hepatitis, for example, the last years. Okay, so you can give the next one. Click several times because it's the natural history. You can click, okay, a little bit until 1, 2, 3, 4, 5, couple more. I think that's it. Okay, so this is the natural history of alcoholic liver disease. Everybody that drinks in excess develops some degree of steatosis. And if you continue drinking, you will develop fibrosis, cirrhosis, liver cancer, decompensations. But that is very similar to NAFLD, to non-alcoholic liver disease. But people with underlying fibrosis that drink a lot, they can develop a picture called alcoholic hepatitis or alcohol-associated hepatitis, that they become yellow suddenly, and they become suddenly decompensated. There's a lot of young people, especially in the Anglosphere, in Canada, UK, and America, a lot of young women with these ALHEPs. The incidence has increased massively. Alcoholic liver disease is silent until you develop complications. That is one of the problems. We don't do much to detect these silent or subclinical patients, and we have data on that. We need to go earlier to the disease as happens with NAFLD, hepatitis C, etc. We don't wait until hepatitis C develops liver cancer to treat it, or hepatitis B, as we heard before. We just treat them early. That is the same concept that we have to start to apply it to these patients. Next one. We did a study, and I knew the results. It was a global study, as you can see here. Even Kenya, we wanted Sub-Saharan Asia to be part of it. And we knew the results. I knew the results. We wanted to demonstrate with numbers that compared to any liver disease, alcoholic liver disease is never detected, is never seen these patients early. And we knew the result, but we wanted to provide some data on this next one. So when we compare the amount of patients that we see early when they have subclinical compensated disease, fully functional, versus those patients who have ascites, bleeding, liver cancer, etc. When we compare the ratio, which is the percent, okay, the ratio of early versus late, everything in blue you see more often early than late. For example, hepatitis B is 2 times hepatitis C, and NAFLD is roughly twice as frequently they're seen early than late. Look at alcohol. Number one is 8 times less. So every single patient I see with early alcoholic liver disease, I see 8 or 9 really decompensated, yellow, etc. Why that happens? Because we don't do programs for early detection. The patients don't come with a binary test, which is called hepatitis C, for example. It's an easy test. We need to do early detection in addiction centers, in primary care centers, etc. This is one of the unmet needs, especially in all the world, including in Pennsylvania. Next one. So look at the graph on the left. This is a study that we did with some colleagues in Austria. This is the survival of people in the left. They have advanced fibrosis, F3 or 4 in dotted lines. 40% of them have died in 10 years, versus those without advanced fibrosis. And many of these patients were asymptomatic. We're doing follow-up studies with this Caroline Lackner, the first author, and we just talk in these days because we want to do in these biopsies that were taken then, many years ago, in the biopsy, we could see predictors of you are close to the compensate. You're fully compensated, you're drinking, your bilirubin is 1, but I do a biopsy and we can find markers that you are almost there. You're going to decompensate. Well, doing multi-omics, RNA-seq, DNA-seq, proteomics, etc., in fixed tissue from this cohort now, for example, to bring. But this is not that graph amazing that you detect someone with a silent disease that is 40% chances to die in 10 years. It's not crazy compared to, for example, to a polyp in the colon. You think that detected a polyp in the colon with some dysplasia, these people will have 40% mortality in 10 years. And still everybody does colonoscopy when you are 50, but nobody does early detection of FibroScan in alcoholics. That is incredible. Okay, next one, please. Okay, so next, a new click. Okay, so campaigns to early detection of silent alcoholic. This is the main unmet need in the whole hepatology. Of the four majors, if we have to choose the four major liver disease, hepatitis B, C, NAFLD, and alcohol, by far, silent or subclinical alcoholic liver disease is the most ignored phenotype of type of patients in clinical hepatology, and the numbers speak by themselves. Next one, please. Okay, next one. Next one. Yeah. Okay. You can. Okay. Next one. Click. Thank you. So we want to have integrated teams in academic centers that do both alcoholic liver disease and neuropathy as well, and for example, in pancreatitis, in myocardiopathy, in cognitive disorders. They don't check for organ damage in alcoholics very much, and many of them have neuropathy. Last week, for example, we have a patient with withdrawal with a normal liver that the main problem was a massive neuropathy. She or he was not able to walk because the damage induced in the nerves. You know how many neurologists are interested in alcohol? Very little. When you refer this patient to a neurologist, say it's alcohol, we cannot do anything. We don't want even to see them. So the alcohol is a lot of a stigma for the patient, but it's a lot of subconscious and conscious bias among providers. So we need to pay more attention to these patients because they are our ethical compromise of the society. Next one, please. Okay, so why some people drinking the same, that develop liver disease while other people don't? Why some areas have more alcoholism or more alcoholic liver disease than others? Next one. We did one study that was published that initially, next one, please. Okay, we did a study that initially I thought was a stupid study, like, okay, some postdoc wanted to do some study. Yeah, I'm in Pittsburgh. I never see the sun. I'm from Valencia, Spain. I'm not suffering depression, but sometimes I'm kind of blue when I don't see the sun and it's so cold here. Let's do a study to see whether the colder, the less sun hours you have in a place, the more you drink, the more alcoholic liver disease. And I didn't realize that was the first study ever published in that matter. The first study showing that cold weather and lack of sun leads to alcoholism and to alcoholic disease. It became viral. The only study in my life that will become viral. I was, for example, in BBC interview, for example. The funny is that is linked to another slide I will show you later. There were many theories why, because when you have a warmer place and alcohol dehydrates you and is a vasodilator, you cannot drink so much. And it's thermogenic. When it's cold, you tend to drink more because it will make you feel a little more warm. No? But then there was another thing that a lot of journalists asked me is, what about the sun vitamin D? And that is something that is linked to another thing that I think is kind of cool. The lack of vitamin D leads not only to depression, that is well known, but also to addictions. Okay, and vitamin D is a powerful antioxidant, antifibrogenic, and also hepatoprotective. So maybe not only you're predisposed to drink, but also you're more predisposed to alcoholic liver disease. Next one, please. Next one. Okay, so this is a study that now is, we have submitted this, but this is a poster that we presented in AASLD. And I wouldn't go into detail about the, you can find in internet, and whoever is interested, is that we went to the NICE database, the database of hospitalization in America, and we found that patients undergoing bariatric surgery compared to other surgeries, they were predisposed to vitamin D deficiency, alcoholism, and alcoholic liver disease. And we see a lot of these patients with alcoholic hepatitis. There is different theories. One theory is the vitamin D deficiency will make you more addictive. Another thing is a addiction transition. They go from a solid to a liquid addiction and many other or changes in the microbiome, etc. But we need to monitor people with the bariatric, especially the all more bariatric surgery with bypass, not the restrictive endoscopic bariatric surgery, but bypass people. They are very prone to alcoholism, and the alcohol is not well metabolized. It stays in the body forever and can cause you more alcoholic liver disease. We have quite a bit of these patients in my clinic with bariatric surgery. Okay, next one. Okay, so the number one, of course, as in the previous talks, there is nothing better to improve the hepatitis C induced liver disease than to cure the hepatitis C. The same to control the hepatitis B. There is nothing better to treat alcohol liver disease. Stop drinking. Okay, next one. We did a study. Next one. Did a study from my Barcelona cohort in the past that showed that we follow up the patients for 13, 14 years after an episode of ALHEP. We found that patients with any kind of relapse do much worse than patients with abstinence. But of note, I learned two things from this study. Number one, is late. Many patients who complete abstinence still die, so need transplantation. So that is another argument to say we need to go earlier. And many of these patients, when you see the notes, they went to the PCP or the primary care with some degree of alcoholism, of abnormal liver function tests, and it's kind of nobody took seriously. They never. I know the patient population is not easy, but I try to be a little more. How can we improve ourselves to help these patients? So I think some of these patients even have some jaundice episodes. They were yellow sometimes. They stop drinking. The yellow went away. They then develop ascites, and nobody sent them to addiction therapies, for example. So we need to have much more awareness to treat these patients early. What is the second thing that is not said in this slide, but I learned from this study? Because studies make you more critical and better doctor, in my opinion. 2/3 of the people that relapse after 1 year, and 1/3 after 5 years. What does it mean? That I never stop talking about alcoholism, no matter how many years out after an episode of alcoholic hepatitis. Never. Every single visit that my fellows and the people that have run with me, they know it, I always start with the alcohol problem. Are you drinking? Are you not? In a not confrontational way, we have to do a colleague, a good partner with the patient, but we have to deal with this problem no matter how many years they're out. They're still in a risk to relapse. Okay, next one. Next slide. Okay. So this is a study that, sorry, that is a poster that is a not very kind slide for you guys, but we are also writing this paper. This is a paper that we analyze a genetic and non-genetic prediction of relapse in a large cohort of ALHEP patients. What we found is, number one, the genetic determinants didn't play a role. And we have confirmed that with a lot of data. Second thing, there are two main populations. Let's be simplistic and binary. There are two major populations of ALHEP: younger ladies and older men. Of course, this is too simplistic, but these younger ladies, a lot of them with abuse, with sexual abuse, PTSD, they have the tendency to relapse more than older men. Okay, more. And we have data here that younger age and gender could be. And I have been 20 years just devoted to this disease, and we have now patients in the high 20s. I have patients in even the low 20s, mid 20s, 30s. There's an epidemic of young ladies, and our counselors are playing a key role. We have an amazing counselor, Kristen, that we hire in UPMC, and she's making a big difference. Before we send the patients, okay, find someone. No, now we bring the counselor to the clinic. And this is one of my advice to all of you: whoever treats alcoholic liver disease, bring the counselor to your clinic, work as a team. I think we have learned from each other a lot, the counselor and myself, and I am much better now with the alcoholism because I have seen the counselors acting, all the comments on the patients. When you work in multidisciplinary teams, where you work with people with other expertise, you grow a lot. When you're in the same bubble with a niche, a silo, always with the same people, you're kind of stuck for years. Okay, this is since I have gray hair, I can give the young people some advice and to grow as a doctor, as a provider. Okay, next one. please. Thank you. So a little one more click. One more click. Okay. So when we say personalized medicine, everybody thinks in genes. We have to do a genetic testing to identify your genes to treat you according to your genes. When I talk about personal medicine of patient-centered medicine in patients with alcoholism, and I want you to focus on the right panel there, which is the associated, the underlying condition. If you don't treat the underlying condition, no way you will cure alcoholism. We have to see whether they have PTSD, many times sexual abuse in these younger ladies, depression, anxiety, sleep problems, pain problems. A lot of people have family history of alcoholism. The parent matters. We do and the mother. We are father and mother. We are doing a study now with the NIH, trying to find the impact of first-degree relatives with alcoholism. But I am not an specialist trying to dig in that, but you have to, even a liver or a GI, especially a general specialist, an APP, whoever, have to be able to dig in a little bit in the medical history, identify any of these factors, and then send to the appropriate specialist. For example, some of my patients, I have to say that with a lot of PTSD, they have such an anxiety that anxiety medication is alcohol. So it's difficult to treat anxiety. You have an advanced liver disease with benzos, for example, it can cause encephalopathy, but we have to treat with another surrogate. We cannot allow them to treat with alcohol. And if we don't give anything and we don't do psychotherapy and other drug or medicine, no way they will start drinking. No way, they are unable, even if they want. Okay, next one, please. Okay, so let's go to different, I talk a lot about alcoholism because I think is number one, where I can be more helpful to you because it's my expertise all my life with these patients, but also because it's the number one thing. But let's go to other approaches to treat alcoholic liver disease. One of the main hot topics is always about if giving prednisolone or prednisone to ALHEP or not, what do you think, etc. You follow my Twitter, you will see some tweets about these recently. Okay, next one, please. 2 clicks, 1 click is and the next click. Okay. So one of the tweets I tweet a couple of 3 months ago, 6 months ago, last year is to say, hey guys, it's the 50th anniversary of the first trial here in the left-hand side of the first New England giving prednisolone or prednisone to ALHEP. And still 51 years later now, is the only approved therapy. It's not sad. We have only one thing that improves 1 month survival. That is the same thing that was proven 51 years ago, nothing new, okay? This is the STOPA trial on the right-hand side, the newest with very similar result. Prednisolone is the only thing that works, but works only 1 month, which is not great, okay? Next one, please. Okay, so recently we have created a global network called Global ALHEP, that now with this Juan Pablo Arap, we have built a community of, I don't know, and we have now 150, I think, centers all over the world to do big data studies. And this is one of the first studies we have published last year in Journal of Hepatology. This is when the cortisone are more effective depending on the MEL. The MEL is the best prognostic factor for these patients. Please use the MEL, don't use the MADRI anymore because it's by far the worst, okay? And you have here a gradient, sorry, previous one, sorry. Okay, the darker it is, okay, shows when it's more effective. Basically, I will only give cortisone between 21 and 35 to 40. Before 21, 22, and after 40 is futile, the MEL, okay? When you see these patients in dialysis with a 42 MEL, cortisone will do nothing and will predispose to infections. There's a lot of people in the world not giving cortisone because only improves 1 month survival and not 3 months. I don't have a strong arguments against that, okay? I think still works, but it's only 1 month, okay? And you can use that early Lille at 4 days instead of 7 days, as we published several years ago with Andres Duarte Rojo. Next one, please. Okay, so I want to give you a little novelties. Okay, we have to treat alcoholism. We have to find the underlying cause. Prednisolone still has in certain male patients still can work at least to improve 1 month survival. But what else is cooking in the field? What is anything that is turning me on as a new medicine? I will share with you some data. I think is exciting. Okay, next one, please. So the first thing we wanted to do, next one, please. Okay, is when I started to do studies, molecular studies in ALHEP, everybody say, okay, it's a exacerbation of hepatic inflammation, and then we give cortisone. Just next click, please. Okay, it's basically PMN, so we give cortisone that removes PMNs, and the patients improve. That it was the paradigm for 40 years. Okay, next one, please. Okay, that was based in experimental studies in mice. Next one. Okay, next. Okay, TNF was proposed to be the main factor inducing liver damage in ALHEP, based in experimental mice study. Next one, please. Next. Okay, they did several studies blocking TNF because we have so many good drugs to block TNF, and they saw increased mortality. And this is the trial that killed from the Mayo Clinic that definitely stopped that idea of the TNF blockers to be effective. Because next one, and TNF is essential for defense against infections, and it's essential for liver regeneration. Without TNF, you do not regenerate the liver. And these patients are so prone to infections, plus have a failing liver. So it doesn't seem very smart to block something that is so important for these two things. Next one, please. Okay, so when we did the histological classification for ALHEP, because it was lacking, and we did an international study to develop an histological historian system, one of the things, next one, we found is that the patients with more PMNs, see the right inside, the right picture, have much better prognosis, those with less inflammation. So it was the opposite of the paradigm. The more inflamed liver in ALHEP, the better prognosis. Next one. Next one. Okay, so if it's not intrahepatic inflammation, what it is regeneration or is systemic inflammation? SIRS, systemic inflammatory. Next one. Next one, please. Okay, so one of the first study we did is in a study looking for stem cells, progenitor cells. We thought the more ductal cells, the more progenitor cells you have in the liver, the better you will do. We found the opposite. The more ductal reaction cells you look at these keratin 7 cells, the worse you do. Okay, next one. And that was confirmed in a study by Philippe Mathurin, the one that did in New England. We did a study here in the middle of the explants. This is the explants of people undergoing early liver transplant. There were parts of these ductal reaction cells, progenitor cells. Still, there was a futile attempt to regenerate the liver. They were useless. These patients have a huge liver, is not super inflamed, is de-differentiation of the cells, massive ductal reaction, and failing liver. Next one. And then what about SIRS? SIRS, or systemic inflammatory response. You know from pancreatitis that some patients come with leukocytosis, fever, and they're not infected. It's the spilocytokines. In ALHEP happens the same. Some patients have leukocytosis and fever as a presenting symptom of ALHEP without having an infection. We show also in a study that no matter you have a sterile SIRS without infection, or you have infection associated SIRS, you die. So systemic inflammation leads to multi-organ failure and death in these patients. Next one. Okay, so we revisited completely the paradigm from the last century and the first decade of this century, and we say severe ALHEP is characterized by inefficient regeneration and systemic inflammatory response. So we have to treat these two things. Okay, let's try to regenerate the liver and stop the SIRS. Okay, to cure this patient. Next one. Okay, so this is the current, and I have 3 or 4 slides only left. Okay, so because it's late, I don't want you guys to go too late to sleep. But this is a little the innovations. Okay, where we standing here. So let's start with the antibiotics. because the chances in the microbiome, the passes of PAMs are LPS, for example, bacterial products to the blood. Let's give antibiotics, let's prevent infections from scratch, and then let's improve survival. You will see the augmenting paper that is from the Philippe Maturin group, the one that has done more clinical trials in this field, was negative. They gave augmentin, it was safe. I was very afraid about augmentin causing DILI, but it was not the case. Okay. Rifaximin, we just published last month a pilot study with encouraging results, and I will show you in the next slides. Then let's go to the right inside. Okay. The GCSF, okay, there's 2 or 3 trials, but most of them are, one was positive, another negative, and there are 2 or 3 in underway. Okay, this is a growth factor, but I have to wait to the next trial to see who's positive. Then if we go clockwise, is this obeticholic acid and other FXR agonists are being tested, but be careful, but they can cause liver failure in advanced liver disease. Fecal transportation and changing the microbiome is one of the 2 slides left, is my most exciting thing that I'm the most excited to me in the field. Okay, and anakinra, which is in the interleukin-1 antagonist, we're doing a big trial in NIH now, testing anakinra versus cortisone. And then there are other ones like interleukin-22, etc. The ELAD has been the last attempt to have an artificial liver device. Finally, there was a bankruptcy and the company closed, etc. And I'm waiting for the next company, next investors to invade them. Okay, let me show you the 2 last slides. The next slide is about, I think this slide is in a form of my tweet, because my goodness, I tweeted exactly what I wanted to say I might as well put my tweet. Okay, one is a abstract this year in AASLD showing that fecal transportation can improve the outcome of our HEP. You see the survival is improved. Next one. What is more exciting to me, and you can follow my Twitter, you will see that paper, is that by doing fecal transportation, you cure alcoholism. That is not cool. My goodness. Why I say is this cool? Because fecal transportation, people think in a very, very aggressive way. You can do golly-telly and take some piece of lyophilized microbiome and reconstitute your feces and your microbiome. Okay, so in the future, I envision, and we are talking to companies to do trials in early alcoholic liver disease in our HEP with just cleaning the gut and taking pills. You don't need a nasogastric tube. So that will change the game. And the results are amazing. You treat the cause and you treat the consequence. It's not great. So to me, this is the most exciting in the field that I live with. Okay, next one. And the final slide is about this study we just published of rifaximin. Rifaximin in all patients from admission, no matter they have an encephalopathy or not, it decreases the rate of infection and increases survival. This is a pilot study, but we are trying to do a bigger study now, phase 3, to see if rifaximin is much better than augmentin. Okay, this is all I say in my last slide is about, it's a picture, okay? You can put, is the Castellers, is a castle, human castle in Barcelona, in Catalonia, that there's 9 layers of people. There is this, the guy in the second layer has to be very heavy because I have 7 layers of people on top of him. This is all the hands. I took that picture. This guy needs to go to the second layer. This is how I envision to treat alcoholic liver disease with a strong team around the patient. Thank you for your attention.
Thank you very much. And thanks for ending with a picture from one of my favorite cities, Barcelona. And looking forward, I just was listening to an NPR about La Sagrada Familia. So we'll see, maybe they'll finish it at some point. We'll see. But thank you so much for that talk. You know, I think it is, I mean, it's kind of sad. It's been 50 years and all we have is prednisone necessarily. So, but if we can get rifaximin, how wonderful would that be? Unfortunately, insurance companies make us go through a lot of hoops to get rifaximin sometimes. But I do appreciate you going through that and really your insight into the need to have a multidisciplinary team, which is very difficult right now to find the counselors. So thank you very much.
Absolutely.
I'd like to thank all the presenters for sharing their knowledge and expertise. I really think this was a wonderful and highly thought-provoking educational event. So thank you very much. Dr. Babich?
Thank you, Karen. I just as a reminder for everybody about CME credits, please keep your eyes out for an email from Allegheny Health Network following this conference regarding applying for CMEs. It will include an evaluation which needs to be completed, and once completed, you can request your CMEs from the AHN system. There is a reminder, Jill had mentioned earlier, I want to refresh everybody's memory, there is a relatively narrow window to claim that. So the site is only open till 6 a.m. tomorrow morning. So if you're like me, I'm going to jump on right after this. Tonight's program will provide 2.75 Category 1 CME credits.
And lastly, of course, we would like to thank our program planners, Jill Harlan and Dr. Julie Marone. Thank you to our sponsors one last time. So thank you very, very much. Without them, events like this, of course, could not exist. So everyone have a wonderful evening, and thank you so much for these engaging talks.
And thanks to you, Karen.
You too.
Susanna, CLA, good night. Thank you so much. Another great year.